Yes, finally we are able to connect. Vani ma'am and Ravi sir, welcome. Santosh sir,
Yeah,
welcome from our on behalf of our Ravi Metropolis. So
yeah.
shall we get started, ma'am? Do you have the PPTs loaded in this laptop as well?
That is pending, Aditya, and
Uh,
we had actually put it in another laptop.
uh,
We will somehow transfer it to this ASAP, and I think
shall
we
we
can
get
start.
started with the
We can
presentation now,
start meanwhile,
please?
and just a brief introduction
Introduction.
that. Four of us pathologists from Mavi Metropolis, we will be discussing 10 cases today, and we are very thankful to KCIAPM and School of Pathology and Dr. Aditya for giving us this opportunity as every year, as a tradition we have been doing, and we are very grateful for this opportunity. I think we will go ahead with the presentation.
Thank you, ma'am. So we'll get started without wasting much time now. I first invite Dr. Asifa Sultana to present from Navodaya Raichur to present case number one. Dr. Asifa, over to you.
Hello, sir.
Yes.
Yes, sir.
Please share your screen, share your presentation, and go ahead.
My presentation. Okay, sir. Yes. Hello, sir.
Yes. Put it on slideshow mode and
Is my
get started.
screen visible, sir?
Yes,
Answer.
yes, yes. Go
Okay,
ahead.
sir. A very good afternoon to everyone. Myself, Dr. Asfia, third year postgraduate from Navodaya Medical College. So today I'm going to present case number one. The given case details are 62 years old female and excision of recurrent scalp tumor for HPE. And two images of above case were provided, 1A and 1B. Based upon the history, it is an elderly female. We should think of some DDs that are either it can be a benign or a malignant condition. So, benign, we can think of epidermoid cyst, pilar cyst, or lipoma, or pilomatricoma. And coming to the malignant, we can think of either it can be SCC or basal cell carcinoma, malignant melanoma, or some cutaneous metastasis. Let's move forward and look into the slides. So this is a scanner view of 1A slide where we can see multiple tissue bits over here. And yes, at a little low magnification, we can see here it is a skin with adnexal structures, and in the dermis, we can see a cystic lesion over here. At a higher magnification, we can see this is the cyst wall, and there are some inward proliferation of the cyst wall. And the cyst, the lining epithelium of the cyst, we can see it is stratified squamous epithelium, and these inward proliferation are also showing stratified squamous epithelium with abrupt keratinization. At a higher magnification, these squamous cells are monomorphous and they are lacking a prominent granular layer and showing abrupt tricholemmal type of keratinization in the cyst cavity. And the cells closer to the cyst cavity, they appear swollen and they are filled with pale cytoplasm, and some cells also show cytoplasmic vacuolation. And another focus which shows mild cellular ATPI in the form of enlarged nucleus, irregular enlarged nucleus, and hyperchromasia. This is the scanner view of 1B slide, which shows similar histomorphological features along with a smaller cyst in one focus. So this is the cyst wall and lining epithelium. And these are the prominent infoldings of the cyst wall into the lumen, forming a interlacing bands and lobules. Another focus shows a granulation tissue over here. And the cellular features are similar morphology, that is monomorphous squamous cells lacking a granular layer and showing abrupt tricholemmal type of keratinization. And this is the smaller cystic lesion with above mentioned similar features. So my microscopic summary of 1A is the sections reveal structure of skin accompanied by adnexal structures, and the deeper dermis shows a cystic lesion that is lined by stratified squamous epithelium lacking a prominent granular layer and exhibiting abrupt tricholemmal type of keratinization. Epithelium demonstrates areas of inward proliferation, forming interlacing bands and lobules with abrupt keratinization. Next, individual cells are polygonal with hyperchromatic nucleus. Cytoplasmic vacuolation is observed in some cells, and focally mild cellular atypia is noted in the form of irregularly large nuclei and hyperchromasia, and mitotic figures are occasional. Focal granulation tissue is seen, suggesting possibility of cyst rupture. Stroma exhibits a moderate inflammatory cell infiltrate along with congested proliferating blood vessels. There is no evidence of infiltration into the adjacent tissue. Image 1b shows similar histomorphological features with an additional morphologically alike smaller cyst. So, my probable diagnosis is proliferating tricholemmal cyst scalp. And the differential diagnosis which we can think is proliferating tricholemmal cyst and pilomatricoma. So these two tumors, the differentiating features are nature-wise, both of them are benign, and the age group is in the pilomatricoma, it is seen in the children and younger adults, whereas PTC, it is more common in the middle-aged and elderly females. And the histomorphologically, the pilomatricoma shows irregular shaped islands of epithelial cells composed of basophilic cells and ghost cells. Whereas in PTC, there are lobules of squamous epithelium with tricholemmal keratinization and minimal atypia. Next, mitotic activity is low in both, granular layer is absent in both, and malignant potential is rare. Whereas recurrence rate is moderate if it is incompletely excised in proliferating tricholemmal cyst. And surgical excision is the treatment of choice for both. Yes. Thank you, sir. I thank KCIPM for giving this opportunity for Navodaya Medical College to present a case, sir. Thank you, sir. Hello, sir.
Yeah,
Yes.
video. Can you can you hear me?
Yes, sir, I
How's the
can.
presentation?
Sir.
Yeah, I think that's a good presentation. Okay,
Yes, sir.
and I think you have discussed everything, but I'm not happy with your differential diagnosis and also discussing about the keratinization of the epithelium is this keratinized epithelium, right? So
Okay,
these
sir.
two points I think I need to discuss. Okay, can I
Okay,
put
sir.
my case? Yeah.
Dr. Asifa, please stop sharing the
Can
screen.
you
Yes, sir. Yes,
will
sir.
share image?
Yeah, I can see. Confirm.
Can you see this? My slide?
Yes, sir. Please put it on slide show more.
Yeah, good. Great. Yeah, yeah. Thank you. So, yeah, so I want to just discuss one of the few salient points because she's doctors already discussed everything in detail. So coming to the first, clinical details, it's a recurrent scalp tumor. So that we have to keep in mind. Number one. Number two, when you're looking at the shape and size of the lesion, what we have mentioned here is a 1 centimeter diameter. So that means it is not a growing kind of a tumor. There's no irregular growth or whatever. It is a round lesion almost, with a 1 centimeter diameter. So these two are the important point that we need to look at, doing a grossing and looking at the clinical data. Now, she told about the tricholemmal keratinization. Yes, it is one of the important hallmarkers, some of the very important, tumors of the adnexa. So what you see here, basically, let me just show you. Just a second. Hmm. Okay. Anyhow, I think you can see here the epithelial layer. There are two types of epithelial layers you can see. One at the bottom is basaloid like so they're little darker, they're smaller, and then they are actually differentiating into what is called as this squamous kind of a epithelial cells. They are large, they are pale, they have pink cytoplasm, and some of them have prominent nuclei as well. And they abruptly they keratinize. That means there is no maturity of the epithelial cells you see here. From the basal layer, usually what you see is a granule layer, then it will come, pycnotic layer, then it will go to the corneal layer. So those are the maturity what you see in a particular epithelial cells, right? In a skin tissue, I'm talking about. So here abruptly it will keratinize without any maturation. That means there is no granules at all. This is what is called tricholamel keratization. This is very, very important because this type of tricholamel keratization in so many conditions, especially of the hair follicular unit tumors. Okay, so this has to be kept in mind, and you should, if anybody has any doubt, please have a look at this particular slide again. Another point I think if you are not mentioned, I thought I must show is the presence of a basement membrane, like a thick membrane here. You can see here, and from where these basiloid-like cells are coming up, and then again they are differentiating into the epithelial cells. Then there is an abrupt keratinization. Okay, the location of the tumor. This is very, very, very important. In most of the administrative tumor, we make a mistake when you don't localize the tumor, whether it is epidermal, whether it is dermal, whether it is, in the junction, or it is deeper damage, or it is in subcutaneous tissue. So location is more important in these kinds of tumors. Here, if you look at the epithelium, it is far, far away from the lesion. So this particular lesion is actually doctors already told is a cystic lesion containing lot of keratinization, right? So it's a dermal tumor. Same thing to show that it has lot of materials inside the you know cystic area in the central part. So let us see. So immunohistochemistry is not required. I'm not going to detail about the histopathology. Now let us see what are the key findings. Key findings is one is it's a recurrent tumor. So whenever you say recurrent tumor, you think of a malignancy, isn't it? That's number one thing you have to keep in mind. Then next one is it's a multilobar tumor in the dermis. There is a peripheral palisading of small basilar cells differentiating into large keratinizing. Okay, and there's a thick vitreous membrane also we have seen. Then abrupt tricholamel keratinization also observed. I think she also showed some areas of atypia in some areas. Okay, and there is areas of calcification and also cholesterol cleft in the central areas where it is very obviously seen. No, when you come to a discussion of a tricholamel kind of a keratinization, we have only very few kind of differential diagnosis which you should make. Those tumors which will have what is called as a tricholamel keratinization. So what are those tumors? It could be a benign tricholamoma, it could be a ruptured tricholamal cyst, it could be a giant tricholamal horn, or it could be proliferated tricholamal cyst or a tumor, or you can call it as tricholamal carcinoma also, to do one of the differential diagnosis. And one of the other most important, for a young pathologist is a squamous cell carcinoma. The moment they see keratinization and there's a big cells with little ATP and all that, they put it as squamous cell carcinoma. So that's the differential diagnosis. So all your differential diagnosis has to be in those areas because tricholamel keratinization is seen in even malignant lesions also of the tricholamel tumors. So if this malignant, benign, or intermediate, the one histological hallmark of all these diseases is tricholamel keratinization. Okay, so these are the differential diagnosis. There is a rupture tricholamal cyst, we call it as basically it's a clinical diagnosis because you see rupture basically into the area where it is created. Will not have a lobular solid areas, it will have only cystic areas. Coming to the giant tricholamel horn is again a clinical diagnosis. But when you go into the depth of the lesions, you actually see a tricholamel cyst at the base of this lesion. But important thing is for him to understand for a younger pathologist is the tricholamoma, which is a benign counterpart of the tricholamal carcinoma, right? These are all the very small lesions. They're less than 8 millimeter. They are only confined to the epidermis. You can see in both picture, it's only confined to the epidermis. Here also you can see, and they'll have a tricholamal differentiation, which are pale cells of lower infundibulum. So whenever you see the in the the cells coming from the infundibulum, they'll be always in the epidermis. They'll never seen in the dermis. They can be extended to the dermis, but the origin of the cells will be within the epidermis. That is one point we need to look at. And they'll have a prominent base membrane. Actually, you can see here the base membrane. I think this thing is not working actually. I don't know. Let me go back. Yeah. So This also can be seen, multiple trichomomas are seen in the Cowden syndrome. These are a very benign lesions, absolutely confined to the epidermis. But because it forms a very, what you call trichomomal kind of a keratinization, it has to be under one of the DDs. The other DD could be trichomomal carcinoma because they also, have what you call the trichomolar kind of keratinization. Huge amount of keratinization will be seen in these tumors also. These arise from the cells of the outer, root differentiating into hair follicles of the isthmus. In fact, the isthmus cells are the outer cells in the isthmus, outer layer of the, the hair follicle in the isthmus are the one which have preponderance to do a huge amount of keratinization. That's why you see a lot of keratinization, that is trichomolar kind of keratinization in these tumors which are usually come from the isthmus. That's one thing we have to keep in mind. Of course, it's common in face, neck, and other areas. And what you see is a cellular atypia. You see mitotic activity, foci of trichomolar keratinization, and if you want to do PS positive cells, can be seen in sometimes in the vegetal forms in the epidermis. But basically, what you want to see is a infiltrated type of growth of these tumors, which you can see in the first picture where there's pushing border to the adnexal structure, and in the last picture you can see a very good amount of mitotic activities. Lot amount of mitotic activity with kind of atypia, everything can be seen. And usually we can do, if you want to do some immunohistochemistry, people who are fond of doing that can use CD34 or P53, they'll be positive in some of these cells. So our final diagnosis for this is a proliferating trichomolar cyst, more common in the middle age or maybe little elderly females. 90% occurs in the scalp. They are all very benign, tumors. And when you think of, malignant, this counterpart can become, malignant because of the one into important clinical data you should always have with the rapid growth more than 5 centimeter, which is infiltrating definitely with a lot of metastatic activity, we can consider it to be malignant. Okay, that is one thing clinically you must also suspect. Looking at the size and the rapid growth, within few months, 6 months, you'll go up to 5 centimeter. Now, the important part is the thing to know about the hair follicular structure, because this is the area of concern. Because unless you know the structure of the hair follicles, you will not able to exactly find out from where these tumors are coming, where are they placed, whether they are placed in the epidermis or in the dermis or in the deeper dermis, unless you know the structure and the origin of these tumors as well. So this hair follicular structure is, divided into upper infundibulum, which is almost always confined to the epidermis. So any cell of origin coming from infundibulum will have only in the epidermal region. Then the most important is the isthmus. Isthmus is the middle part of the hair follicle. From the isthmus, many of the tumors will arise, including our trichomolar carcinoma as well. And those isthmatic cells, as I said earlier, they produce a lot of trichomolar keratinization. Then we have suprabulbar and the bulbar area. This is called the inferior part of the hair follicles, and these contains in the bulbar area contains germinal centers, germinal epithelium, and also hair matrix. So if you know this origin, so how do you say this is infundibular or isthmus? There's a key. For example, if the sebaceous duct open into the hair follicle, from there to the insertion of the erector pylorus, we call it as isthmus. And anything above this, origin of the duct of, insertion of the duct, sebaceous gland, that is called the infundibulum to the top layer, and then what is below the isthmus is the suprabulbar of the bulbar areas. So this is how we must actually look at the structure and find out from where these tumors are coming. So what I made is I have made a small, this is not fully validated, but I have done on my own, something like a table to look at the origins of these tumors, which are coming from the hair follicles. So before that, I'll go to the, a classification of the follicular differentiating tumor, like trichoblastoma. Some are benign, some are malignant, pilomatricoma, tricholemoma, trichofolliculoma, etc., etc. There is also malignant counterpart, like we have pilometric carcinoma, proliferative trichomolar tumor. Now it is now in the, I think, latest edition of the skin tumors. They have now put it under malignant category. It is questionable again. We will not discuss that in detail, because when I come to the discussion about the proliferative trichomolar tumor in the same textbook, we see that they are given into three types. One is benign, the other one is the intermediate, the third one is the malignant counterpart. So it is little confusing. Let us discuss it a little later on if time permits. So trichoblastic carcinoma and tricholemal carcinoma are the malignant counterpart. Now with this, I'll go back and show this particular table. So you can see this. The cell of origin, if it is pan-follicular, it will be in the dermis because all the cells of the follicular unit will be present here. So trichofolliculum is a dermal origin. Then melanocytic matricoma is a melanocyte that is present in the bulbar region. It has to be in the dermis again. Lower dermis, I would say subcutaneous. Sometimes you can see in subcutaneous tissue also. Because these are cells which go in depth to the system. Then we have trichoblastoma, trichoblastic carcinoma. That is our, but it's a biphasic tumor. It has both epithelial and sarcomatous, element. So here again, it is arising from the germinal epithelium. That is the epithelial part, and the matrix is the connective tissue part, right? So again, this is present. Where does it present? It is present in the matrix and germinal epithelium is present in the bulbar area. So it has to be in the deeper dermis. Okay, the pilomatricoma or carcinoma, what doctor was discussing about, is a coming out from the matrix and also the hair cortex. So where do you see that again? It's in the dermis, right? So it has both benign and malignant counterpart like that. You can also have trichoblastoma, trichoblast carcinoma as both benign and malignant. Now coming to the proliferative tricholemal cyst, what we are discussing today, it is from the outer hair sheath cells at the isthmus. Okay, this is very important where you will get the tricholemal carcinoma also. As I told you, it can be benign, it could be intermediate, it could be malignant as well. Now, coming to the infundibular tumor, there are two tumors coming from the infundibular epithelium. That's the tumor of follicular infundibulum and the tricholemoma, both are benign and they only exist in the epidermis. You can't get it in the dermis. They can push down if their growth is little high. Now, trichodiscoma is a spindle cell neoplasm. It usually occurs in the ischemic part, that is the pre-ischemic part of the connective tissue. Because it is arising from the connective tissue, there are spindle-shaped cells. Again, you see in the dermis and it's benign in nature. Now, the last one is, again, the pilar sheath acanthoma, where, you get this, sorry, yeah, you get this in between the infundibulum and the isthmus, and almost always you see both in the epidermis and the dermis. So this is also benign lesion. So the take-home message is that be familiar with the terminology used in the adnexal tumor. It keep the classification keep changing every now and then. So somebody has to follow the latest WHO classification. If there's a problem in understanding this tumor, I must discuss with the expert whom, if you have somebody in your place, and know the origin of these cells to understand the histology and location, and understand the concept of tricholemal keratinizing, because it is very, very important to make sure that you don't miss tricholemal tumors. So these are the reference for I have taken, not too many things. Okay, thank you. So is there anything question and all that, we can take it up now or later? I think, I don't know. Aditya will take the question now. What to do now? What to do? Can we take question now or afterwards? Aditya, can you hear me? I should stop sharing.
Noted, sir.
Aditya, can you hear me
Sir,
now?
yes, yes, sir.
Yeah.
Shall we?
Anything, anybody to have any question now we should take or later on?
We will take in a chat box, sir. I request all delegates to post the queries
Best.
in chat
Yeah,
box,
great.
and we
Okay.
will take the
Okay.
questions from there.
Okay.
With that, I think we can move to case number 2. That will be presented by Dr. Daneshwari from SDM College of Medical Science and Hospital. Dr. Daneshwari, over to you.
Good afternoon, everyone. I'm Dr. Daneshwari Manandi, second year postgraduate from SDM College, Dharwad. The case allotted to our institute was case number 2, a 43-year-old male, biopsy from the intact bulla, lesion from the left leg as well as left forearm. So here in the scanner view, we can see two skin tissue bits with intraepidermal bulla present. Then the epidermis shows the intact bullous lesion, whereas the dermis shows the skin adnexal structures. So in the higher magnification, we can see the bullous lesion with very few inflammatory cells, and the surrounding keratinocytes show multinucleation. Nuclear molding is seen. You can see multiple cells with nuclear molding, cell ballooning, and margination of the chromatin. Also, ground glass appearance of the nucleus is seen. Here we can also see few inflammatory cells. The dermis shows inflammatory cells composing of neutrophils, few eosinophils and lymphocytes, along with plenty of lymphocytes surrounding the adnexal structures. So to summarize, two skin tissue bits with intraepidermal bulla and very less inflammatory cell debris, keratinocytes showing ballooning, acantholysis, multinucleation, margination of the chromatin, and nuclear molding, whereas the dermis is showing plenty of inflammatory cells composing of the neutrophils and lymphocytes. So my final diagnosis was herpes simplex virus infection. The other differential diagnosis with overlapping features are monkeypox, whereas the lesion here in monkeypox is umbilicated lesions, and the lesions can progress from macules to pustules. We can also see epidermal necrosis and dermal lymphohistiocytic infiltrate in these lesions. The other differential is bullous impetigo. This is most commonly seen in children. The bullae are honey-colored crusts and flaccid bullous. Subcorneal blisters are present with very minimal to absent dermal inflammation is seen. The other differential is eczema herpeticum, which is also known as Kaposi verruciliform eruption. There is systemic symptoms present in these conditions with widespread vesicles and erosions, with pre-existing skin lesions like atopic dermatitis, which can show spongiosis and inflammatory infiltrates. Thank you.
Dr. Dhanashri,
Yes, sir.
what's your diagnosis you made?
So herpes simplex virus infection.
Yeah. And you said monkeypox and some
They are my
vesicular bullous lesion.
differentials. Yes, sir.
Why you say differentials of vesicular bullous lesion in children?
So the nuclear features and like ballooning and all, the nuclear features were matching with the lesion. That's why I took that as one of my differential diagnosis, sir.
Okay. But you're not seeing classical picture of the those cells which are present in the second present in the bulla.
Yes, sir.
Can you see my slide?
Yes, sir, I can see, sir.
You can see? Yeah. I think this is a very simple forward slide because usually people don't do biopsy for a herpestic lesion, right? So because this is a generalized herpetic lesion. So where do you see a generalized herpetic lesion? You're not getting?
So,
Where do you see generalized herpetic lesion? Because this case was, they also thought probably it was,
hello, sir.
I think, can you hear me?
Yes, sir.
Now. You can see my slide now?
Yes, sir.
Yeah, great. Anyhow, nothing to worry. I'll answer that question.
Yes, sir.
Okay, so this is actually a vesicular bullous lesion all over the body since 4 days in an elderly male, right?
Yes, sir.
They have done two punch biopsy because they think they thought it's a vesicular bullous lesion. They never thought of a herpes. Usually, we don't get herpetic lesion as a skin biopsy. That's why I thought I'll share with each and every person. Okay, this is the histopathology which I think you already discussed. There's a periadnexal lymphocytic infiltrate, and where do you see the bulla? It's the
Intraepidermal.
very good. right? Did you see the inclusions and multinucleation, molding, and all that?
Yes, sir.
Very good. So this is a microscopy. Can Yaram says here that it's a intraepidermal bulla. There is no doubt about that.
Yes, sir.
Number two, and here it is what we saw and what you also saw is the multinucleated giant cells, right?
Yes, sir.
And there is a some amount of molding also you have seen, right?
Yes, sir.
Correct. Apart
Yes,
from
sir.
that, you see some lymphocytes and neutrophils. Okay.
Yes, sir.
Otherwise, there is some amount of edema, then inflammatory infiltrate and all that, vasculature, increased vessels and all that is a part of the lesion.
Yes,
Okay.
sir.
Now, yes, we also gave the same because I don't want to again waste time in looking at those slides. We also give the diagnosis of intraepidermal blister with a wide viral cytopathic effect consistent with herpes infection, right?
Yes, sir.
Okay. Now, is it enough to say just herpes and keep quiet? We have to type it right.
Yes, sir.
Can you able to type it looking at the histopathology?
Not sure
You
about
can't,
that.
right? Yeah.
Yes.
So can we have a better test which is cost effective and has better tag? Can you do that for herpes or any of those lesions? Anybody? Should you do only always histopathology to make a diagnosis of herpes simplex or herpes zoster or herpes
And we
even
can,
simplex 2?
Zank smear
Not
can be done,
necessary,
sir.
right? Yeah, we can do Zan test, correct. Okay, so this is a case of general herpes. So again, I'm stressing this point. Why I'm stressing this is usually herpes, whether it is HSV1, 2, varicella zoster or herpes zoster, they have a proper presentation, except the varicella zoster, which is generalized in nature, especially the primary one. All the secondaries one will be localized, right?
Yes.
So that's the importance here. Okay. Yes, we have a rapid diagnosis called ZAN test. Hope everybody must be doing this. We do get a lot of cases like this. Okay. And this takes around 30 to 60 minutes to report. Just you have to scrape the bottom of the blister and then put it on the slide and do your Leishman stain exam. That is more sufficient to look at the acantholytic cells, what you can see in this picture, and the multinucleated large giant cells, right? So apart from this, what you should do is a blood test for specific IgM, which can be demonstrated during acute phase or a week after the symptoms. Okay, these are very, very important. If you're not
Yes.
able to make a diagnosis, which herpes they want to treat, and because there are so many complications of herpes nowadays, what we see, okay, so it has to be properly diagnosed to give a complete diagnosis. Don't do IgG because it takes very few more weeks for it to develop and it stays longer. And even if a secondary infection is there, IgG will be always positive. Most of the herpes zoster patient will have always IgG positive because they had earlier infection with the chicken pox, right?
Yes, sir.
So this is one thing. IgM has to be done with paired sample. That is number one. Number two, we should also have a confirmatory test either by PCR by using the blister fluid, or you can do a culture. Culture again, these cultures are not available routinely except probably in some institutions like NIMAS where we don't do this. The rapid culture also now it is available. I'm not sure whether it's available. Within 2 days you can get the report, or you can also use routine viral culture, which takes usually 14 to 20 days, right?
Yes, sir.
Yeah. So the take home message here is so what we are diagnosed here, we also thought of herpes simplex only first. But when it was generalized, then we thought it probably a herpes zoster with a generalized kind of a thing because patient was having some immunocompromised condition. So we had to do some antibody check which they are not interested to do. So we left it at that particular stage itself. So we didn't do any. We did I think IgG or something which is positive, but it's of no use, right? So use
Yes.
a rapid test called ZAN test for early diagnosis, which is very, very important, very useful. And within a day, within few hours, you can make a diagnosis. Perform all the herpes available, especially IgM or the PCR, to ensure proper diagnosis. Histopathology is not the first option to diagnose herpes. Don't ask for people to do a biopsy. Okay, and think of a viral lesions whenever you see an inclusion or a multinucleate cells with molding of the nucleus. Especially we get a lot of these cases nowadays in the endoscopy biopsy, especially esophageal biopsies, because of the patients who are on chemotherapy or having some immunocompromised status. We see a lot of these. Even I think Dr. Santosh has a lot of collections of these, while inclusions in the biopsies endoscopy. You can take one. I think next KCIAPM seminar only on these herpes lesions in the endoscopy biopsies. That's the number of cases he has. So thank you so much. I think we'll
Thank you,
leave
sir.
at this stage. Thanks, Dr. Daneshwari and also Dr. Sultana. Now I'll stop sharing this. Okay.
Next. Thank you, sir. I would like to invite the next presenter of case number 3, Dr. Lipika Rajendra from Akash Institute of Medical Science and Research Center.
Am I audible?
Yes, Dr. Lipika, you're audible.
Is my screen visible?
Yeah, screen is visible. Yeah,
Let's start.
yeah, please.
So, good afternoon, everyone. I'm Dr. Lipika Rajendra, third year postgraduate from Akash Institute of Medical Science. I have been allotted case number 3 in the month of slide seminar KCIPM May 25. So, the case history received was received slide for second opinion, 46-year-old lady with endometrial biopsy. 2 slide labeled as 3A was given. So under the scanner view, we can see multiple tissue bits noted with admixed with large areas of hemorrhage. Coming to 10x power, predominantly we are seeing papillary pattern and we are seeing glandular pattern of growth. Coming to 40x, these papillary pattern and the glandular pattern are lined by columnar cell having round to oval nucleus showing pleomorphism with few showing prominent nucleoli and eosinophilic amount of cytoplasm. At areas we can see squamous morules. In this photo, we can see true papillae which is having fibrovascular core, and these papillae are showing squamous differentiation. At this image, we can see the squamous different. They are atypical. They are squamous, abnormal squamous cells showing coilocytic atypia. So coilocytes are the abnormal squamous cells which is having racenoid nucleus and a perinuclear cavity, hollow cavity. Here we can see few endometrial gland which is showing nuclear atypia. In this image, in this tissue bit, we can see low power normal endometrial gland which is showing scanned endometrial glands, and at high power we can see the endometrial gland which is having a secretory phase of epithelial lining, and it is showing decidualized stroma. So to summarize my finding, section study shows multiple tissue bits composed of tumor cells arranged predominantly in papillary and glandular pattern. These cells are lined by columnar cells having round to oval vesicular nucleus showing pleomorphism, moderate eosinophilic cytoplasm with few showing prominent nucleoli. Occasional mitotic figures are also noted. Also noted are areas of squamous cells in morules, some showing coilocytic changes and some showing mild nuclear atypia. Noted few endometrial glands showing nuclear atypia. Scanned endometrial glands are seen in secretory phase. The stroma is edematous and it shows decidual changes. Inflammatory infiltrates are noted and dense areas of hemorrhage. So with this finding, I would like to give a provisional diagnosis of endometrial adenocarcinoma with squamous differentiation. To justify the diagnosis, IHC is needed. So to differentiate between the origin of the adenocarcinoma, that is between endocervical and endometrium, IHC panel is needed. So if the adenocarcinoma of endocervical origin is there, we should do Vimentin and ER, which will be negative. P16 will be diffusely expressed and CEA will be positive. Whereas adenocarcinoma of endometrial origin, in that Vimentin ER will be positive, PAX8 will be positive, P16 will be patchily expressed and CAA will be negative. One more differential diagnosis which I would like to tell is endometrial serous carcinoma. There also we will have papillary growth with or without fibrovascular cores, slit-like spaces, gland-like spaces, and solid growth. Here, the nuclear atypia will be too high, hyperchromasia will be there, prominent nuclei, and prominent mitotic figures will be there, frequent. Hobnail will be there, and generally it arises in the background of atrophy or often with endometrial polyp. And to confirm the diagnosis, IHC can be done. So first is positive will be P53, P16, PAX8, cytokeratin AE1 and AE3 and CK7, and CK20, ERPR, WT1 will be negative. Thank you.
Hello? Hello?
Hello, ma'am.
Yes, ma'am.
Yeah, am I audible?
Yes,
Yes,
ma'am.
ma'am.
Okay.
And they're on it.
Was it possible? My password, Gmail password.
Stop sharing.
Their screen.
Yeah. Yeah.
This is yeah. So, Lipika, thank you for very good presentation.
Thank you, ma'am.
Regarding the diagnosis, I would say you are partly right, partly wrong. Sorry about it. Uh, Regarding the squamous differentiation, yes, you are right. But regarding the malignancy, I think you are wrong. So let's see how. Let's go about this case. Okay. So let me start my timer. Yeah. See, this we received as take the phone. So this we received a slide for second opinion. See, as you are all aware, in our lab, we get a huge load of endometrial biopsies, and we get a lot of second opinion cases. This was reported outside lab as a squamous cell carcinoma of the endometrium. So imagine getting squamous cell carcinoma in the endometrium. The gynecologist was really baffled and she said, we need another opinion. Do you think squamous cell carcinoma occurs in endometrium? Yes, in something called the ichthyosis uteri, where extensive squamous metaplasia and squamous cell carcinoma can occur in the endometrium. And the microscopic description, as you have covered most of the points, it was a polyp. Basically, see, first thing you have to analyze is it is basically an endometrial polyp, and the polyp showed extensive decidual changes. You could see that glands are so variable in shape, size, so irregular they looked. Varieties of findings were there. And when you go on a higher power, you can see the decidual changes, lot of blood vessels. You can see the glands. These glands, the lining epithelium, they look kind of hobnailed, and they were looking so different, like you could see some clear cell areas, you could see some hobnail areas, and you could see these big areas of squamoid morules or squamoid eddies, and some places like papillae they were looking, which is what has misled you. Those papillary areas, one should be very careful and look at them in detail, because there are so many mimics. See, again, the papillary areas which you were describing and the irregular glands, these glands look compressed or slit like they look, right? And look at the vascularity. And what are these areas? These are the lytic areas. You can see there is a breakdown of the endometrial glands. There's a breakdown of the endometrial stroma. And these are the lytic areas amidst hemorrhage. And these lytic areas, the cells, they really look very dark and very misleading. And look at these again, papillary areas, hemorrhagic areas, and again some more areas you can see, like micropapillae like projections are seen, and hobnailing also is very beautifully seen in this area. Here you can see nice hobnails, right? So all these will definitely, it is a worrisome, it looks. Next, usually we think about IHC. Do you think in this case IHC was required? I felt no, it is not required, and we did not do an IHC for this case. I felt it was more of a morphological diagnosis, and I gave this as my final impression, a functional endometrial polyp with extensive squamous metaplasia and papillary syncytial metaplasia. So basically, I felt that this was a case of a polyp, a functional polyp, because it was a decidualized changes were there. And all the changes what you're seeing are metaplastic changes. That's why I selected this case, that I could teach the postgraduates about metaplasia. See, metaplasia may look easy, but in routine practice, very, very tricky metaplasias. Hence, I selected this case for KCIAPM discussion. All of you know metaplasia. And by the way, this patient, I am in follow up. I even called the clinician and checked. She's doing very well. No further treatment, no further management, nothing of the sort. And she is doing very well, right? So, what is this metaplasia? It is, all of you know, it's a first year topic. Just it differentiates from one cell type to another cell type, but that cell type is not present in the location. Usually it is because of some irritation, inflammation, irritation, hormones, or sometimes associated with hyperplasias. You know the spectrum: hyperplasia, atypia, malignancy. So whenever we see metaplasia, we have to keep in mind, are we dealing with neoplasia? Are we dealing with any hyperplasia? And that should be ruled out. Not only epithelial metaplasias, you can also get stromal metaplasias. Stromal metaplasias are osseous, cartilaginous, myomatous, adipose, synovial. We have seen couple of cases of osseous, just bone tissue, that's all. So that is a stromal metaplasia. Otherwise, commonly epithelial metaplasia, squamous, mucinous, tubal, eosinophilic, papillary, secretory, hobnail. Now, if you go back to the slides again and see it, I am sure you will pick up each and every of these metaplasias in the slide. Okay. So we already have told you it's mainly the hyperestrogenism, that is excessive use of estrogens, a polycystic ovarian syndrome, which is the scourge of the present modern day era, PCOD. So abundant estrogen stimulation, unopposed progesterone. So this again hyperestrogenism, or sometimes with IUDs and with previous hysteroscopic curatages, all these will give rise to metaplasias. Okay. Next, we move on to the differences between a squamous metaplasia and a squamous carcinoma. I felt in this particular case, the malignancy was not the doubt. The doubt was metaplasia versus a squamous carcinoma. That was the area of concern, because the primary pathologist has reported as squamous cell carcinoma. So here we have to mainly focus on infiltrative nature of the glands. If they are infiltrative in nature, only we can call them malignant. If otherwise, the architecture, if it is well circumscribed, we need not call it a carcinoma. Atypia, mild atypia in metaplasia, moderate to severe in carcinoma. Here you showed some coilocytic changes. I would like to tell you that they are not the true coilocytes. They are all the glycogen effect, the empty looking glycogenation or glycogen effect. That is the cause. It was full of decidual changes. The stroma had lot of decidual like changes, which is the progesterone induced changes, and that will give rise to the glycogen effect. It is not a true coilocyte, because you have to see the nuclei. The nuclei was very small and compressed, hence they are not the coilocytes. Okay. The mitosis, again, you have to see keratinization, necrosis. In our case, there was no necrosis. Very important point to be noted. Desmoplasia, very important again. And where exactly these squamous are there? Are they associated with the benign glands, or are they associated with some high grade glands? These are the things we should see in this particular case. Now, I said we have not done any IHC. There was no role of IHC, I told in this case. But for the sake of academic interest, if we were to do IHC, I would have done a squamous marker P63, CK5/6. Both these just indicate squamous, that's all, nothing beyond that. Ki67, low index, high index, probably it would have helped. P16, it would have been negative in metaplasia and strong diffuse in carcinoma. ERPR would have been positive in metaplasia but negative in carcinoma. Beta catenin, nuclear localization in metaplasia, membranous in carcinoma. So practically speaking, ERPR, Ki67, P16, these three probably would have helped in this particular case. Now the next 2 minutes, I will quickly tell you about the different metaplasias. Squamous metaplasia, also called morular, because they appear as morules. See this round modules they are seen. So this usually it is associated with these glands, but commonly we see them with hyperplasias and endometrioid type of carcinoma. We call them squamoid eddies. Also in endometritis we see them. This is the common type we see. In our case, it was extensive squamous metaplasia, which was mimicking and misleading into thinking of a malignancy. The next common we see is the mucinous or endocervical metaplasia. Endocervical, it is not common, normal lining in the endometrium. So metaplasia, I told you, it's a different type of epithelium. So this endocervical type, that is having the tall columnar with basal nucleus, apical vacuolated cytoplasm, we see again around the perimenopause, postmenopausal, in tamoxifen-induced polyps. In these conditions, we see this kind of a metaplasia. Ciliated metaplasia, very frequently we see that even in the normal PP endometrium, proliferative endometrium, we see this kind of a ciliated metaplasia, which is like a fallopian tube. Look at the small cilia. Go back to this case, I'm sure you will find lot of ciliated metaplasia. Sometimes oxyphil, eosinophilic, abundant, thick, dense cytoplasm, that is the eosinophilic metaplasia, oxyphilic metaplasia. Usually we see this in the atrophic endometriums. Clear cell metaplasia, very nicely it was seen in this case. This is important. We should not make a mistake of clear cell carcinoma of the endometrium. So we should be aware of clear cell metaplasia and distinguish it from a clear cell carcinoma. And finally, papillary syncytial metaplasia. Practically, I'm telling you, this is a very, very important. In this case, go back and see lot of areas of papillary syncytial metaplasia. This is nothing but a breakdown, an endometrial lytic pattern, a breakdown due to ischemia, due to regeneration, due to degeneration, which is occurring in either polyps or in hyperplasias. When we describe polyps, we write also seen areas of papillary syncytial metaplasia, because all metaplasias, please describe in your report. If it goes for second opinion, that pathologist will know these are areas of metaplasia and not to mistakenly call them as malignancy. So papillary syncytial metaplasia, you find dark aggregates of stromal balls, blue color, thick aggregates you find. Small papillae they occur. In our case, beautiful papillae you describe. What are those papillae? They are nothing but this papillary syncytial metaplasia. And you get a lot of neutrophils sometimes, you get hemorrhages, breakdowns, stromal balls, fibrin thrombi. All this should alert to you about this papillary syncytial metaplasia. Look at this, how nice a papillary formation it is seen. These are very innocuous, nothing to be worried about and not to be over-interpreted, and pretty common in the routine endometrial biopsies. And rarely, I told you, sometimes even the mesenchyme can become metaplastic, like you're seeing here, fat spaces, adipose metaplasia, etc. So the take-home message in this case is, if the squamous metaplasia is very extensive, please look, are we dealing with any endometrioid carcinoma? Yes or no? Look for stromal invasion, look for desmoplasia, look for atypia. These indicate carcinoma. And when you see extensive morular or squamous metaplasia, be cautious in interpretation. Always correlate clinically. Please pick up the phone, talk to your clinician, get the more information, ask them what they think clinically, and then give out your final impression. And recognition of these metaplasias is very important in daily diagnostic practice. Please include them in all your histopathology reports, especially when there is some complex architectural features. Okay, so thank you. I end the discussion on case number 3. Okay, can you just open the, okay. So there are 2 questions. One is this area stellar reaction? No, these are not area stellar reaction. These are mimickers of area stellar reaction. Why? Because area stellar, generally you see them in association with the products of conception with an ectopic pregnancy. If you have a tubal ectopic, you see this kind of changes here. Decidual changes are there. The hobnailing is there. You are very right in thinking area stellar reaction. But in this particular case, no history of pregnancy, no history of ectopic, and it is not area stellar. It may be a look-alike. Could it be an endometrioid carcinoma with squamous differentiation? Exactly, I told you. Look at the desmoplasia, infiltration, atypia. When these are not there, we cannot call it an endometrioid carcinoma. These are all metaplasia. Squamous differentiation, yes, you are right. Any role of radiology? Yes, radiology in this case, not much. I think the histopathologist's verdict is final. At the most, if it is malignancy, if it is invading the myometrium, you may get some information from radiology. If it is confined only as a polypoid mass in the cavity, I don't think radiology would play a role in this case. Thank you.
Thank you, ma'am. I would like to invite the Dr. Shravya KS from Srinivas Institute of Medical Science and Research Center to present the case number 4.
Good afternoon, everyone. I am Dr. Shravya KS, first year pathology PG from Srinivas Institute of Medical Sciences. I'll be presenting case number 4, which had the following history. 28-year-old female with thyroid nodule, which was excised, and slide was sent for second opinion. This is the scanner view of the slide given, which showed an encapsulated solitary lesion in the thyroid. This is the magnified view of the tumor, which showed microfollicular arrangement, predominantly lined by follicular cells, but few areas showed papillary thyroid carcinoma-like nuclear features. Here, the normal thyroid parenchyma is seen separated by a fibrous capsule from the tumor. The tumor is seen pushing the normal thyroid parenchyma. There's a breach in the capsule seen where the tumor cells are seen lying confined within the fibrous capsule. However, in the magnified image, you can see that the capsule has not been breached throughout the entire thickness. The tumor cells are seen within lying confined within the fibrous capsule. Here, there's another foci which showed a capsular breach. The tumor cells were seen lying within the fibrous capsule. There is no entire thickness breach in the capsule. To summarize the findings, is encapsulated solitary lesion was seen. However, 2 foci showed questionable capsular invasion. Microfollicular pattern of arrangement was seen, predominantly lined by follicular cells. Few foci showed questionable or equivocal nuclear features of papillary thyroid carcinoma, such as clearing and nuclear grooves. The lesion is seen pushing the adjacent normal thyroid tissue. No angioinvasion was noted. The following DDs can be considered for tumors composed of well-differentiated follicular cells, which could have the arrangement of normofollicular, macrofollicular, microfollicular, solid, or trabecular pattern. If the questionable if there is questionable capsular or vascular invasion and no nuclear features of papillary thyroid carcinoma, follicular tumor of uncertain malignant potential can be considered. For a case of minimally invasive follicular thyroid carcinoma, there should be definitive capsular invasion and no vascular invasion. For it to be a case of follicular adenoma, no capsular invasion should be present and no vascular invasion also should be present. Uh, for non-invasive follicular thyroid neoplasm of having papillary thyroid carcinoma like nuclear features, no capsular or vascular invasion should be present, but nuclear features of papillary thyroid carcinoma will be present. For well-differentiated tumor of uncertain malignant potential, questionable capsular or vascular invasion will be present, and partially developed or questionable papillary thyroid carcinoma type nuclear features should be present. If there is frank capsular or vascular invasion, the following DDs can also be considered. Angioinvasive follicular thyroid carcinoma, widely invasive follicular thyroid carcinoma, follicular variant of papillary thyroid carcinoma. Based on all the findings seen, my final diagnosis is follicular tumor of uncertain malignant potential. However, a close DD of well-differentiated tumor of uncertain malignant potential can also be considered because of the papillary thyroid carcinoma like nuclear features seen in few foci. Thank you.
Is it visible? Yeah. So, Shravya, let me start my timer. Yeah. Shravya from Srinivasa Medical College, very neat and clear presentation. I really like the way you presented the case. Whether the diagnosis is right or a little bit different from ours, let us just explore this. I think you're partly right. Okay. So this again, it was a slide for second opinion, and we received the history as 28-year-old female with a thyroid nodule. It was a solitary nodule of the thyroid. So we received only one slide and block. See, first thing, no, when you receive just one single slide and block of a thyroid, immediately you should start getting the suspicion. We need more sampling, we need more tissue, more blocks. That should be there, right? So, but when we contacted them, they said, no, no, it was a small lesion. Very well. We could just make one slide, they said. That's all. So these slides, what you're seeing here, it had a very well circumscribed area of tightly packed follicles was there. Okay. And they were all follicular pattern. When you see this, I'm very happy when I see this. Earlier I used to get scared. Now I'm very happy because you have a beautiful table. You fit that, the table, you get the diagnosis. Something like AI or algorithm based. Well circumscribed, well encapsulated, follicular pattern tumor. That is, go to the table. I'll show you the table next. Okay. So stop sharing. Okay. So when we go in the high power, you can see these follicles and you can see the nuclei. Their nuclei look quite big in size. And here I have compared with the normal nuclei. So Shravya, you said that the nuclei features of PTC were questionable. I disagree with that because I felt that look at these normal follicles, look at their nuclei, compare with the nuclei of the lesion. It is so much more enlarged here and so much of overlapping is there, crowding is there, irregularity is there. And see again here, you can see some nuclear features, the chromatin you can see. Three things we need to see in the nuclei. Nuclear size and variation, nuclear overlapping. The second is the chromatin pattern, the vesicular pattern, and the nuclear membrane. The third one is the membrane. Is there any invagination forming, nuclear grooving like that, or any inclusions forming? These are the three nuclear features we need to see. The nuclear size, the chromatin, and the nuclear membrane, and give a score of 1, 1, 1, and 3 will have to score them. So in this case, I felt all the three nuclear features are definitely there, I felt, okay. So I gave a good score for this nuclear features. See this area again. such enlarged nuclei with overlapping, grooving in some of them, and the vesicular chromatin is there, and a lot of hemorrhage is there. All these points are seen. Now, one more point was about the capsule. You said it was questionable. So here in capsule, what we have to see is whether it is through and through inside the capsule. Then we can give a clear cut that it is capsule is invaded. If it is just playing the fibrous tissue, we will say capsule is not invaded. And we have to see thick or thin capsule. We have to see it is partly splaying the fibers or completely going through and through. All these points we have to see. And in this case, I felt that the capsular invasion is not there, and the nuclear features are present, and it is a follicular pattern tumor. IHC, no, I felt this is more of a morphological diagnosis, and I do not require IHC. Not all cases you can solve by doing the IHC, okay? So we did not do IHC in this case, and I gave out a final opinion as NIF-TP, non-invasive follicular thyroid neoplasm with papillary-like nuclear features. That's why I told you are partly right in your approach. So this NIF-TP, all of you are familiar, the WHO Blue Book has given such beautiful clear-cut guidelines to when you're going to call this NIF-TP. The same textbook I have copied, so we will not go much in detail about these things. Remember the nuclear features, the 3 points, size and shape of the nuclear membrane, chromatin, and give 1 point. If you have even score of 2 also, it is necessary, you can give a diagnosis of NIF-TP because all the 3 features may not be present. Even 2 features is sufficient to call. But you need to show this growth pattern, no papillae, no Samoma bodies, no solid area should be less than 30%, no vascular or capsular invasion, no necrosis, and all these negative points you have to demonstrate. IHC, we could have done a BRAF V600E mutation, either IHC method or genotyping. That should have helped in the diagnosis. So this is a very beautiful table given in the WHO for all follicular pattern tumor. I think Shravya has touched upon it, but I think this table looks more easy to remember for the PGs. You can just note down this table. On the x-axis, the invasion. That invasion means what? Capsular invasion, vascular invasion, thyroid parenchyma invasion. 3 types of invasion. Is it present? Is it questionable? Is it absent? On the y-axis, you have the nuclear PTC type of nuclear changes. Are they present? Are they questionable? Are they absent? So the x-axis, y-axis, you have the invasion, you have the PTC nuclear changes. So first, when you see the slide, make up your mind clearly about these 2 parameters. In this case, I made that PTC like nuclear changes present. That's the first category. On the x-axis invasion, I gave it as absent, but I think Shravya, you're partly right. Questionable is also acceptable, I think so. So what would the diagnosis be now? It will be NIF-TP according to me. And if the invasion was questionable, we would have given it as a well-differentiated tumor of uncertain malignant potential. Now, there are 2 important practical points I want to stress. Number 1, the clinician, most of them do not understand this well-differentiated tumor, uncertain malignant potential, follicular tumor uncertain. They just ask, Madam, is it papillary thyroid carcinoma? Is it follicular adenoma? Is it follicular carcinoma? They will not be knowing the entities. So we have to explain to them what are these entities. Number 2, extensive grossing, very important in this case. 1 slide, 1 block. Is it correct to report? I doubt. We need to do extensive grossing of the entire lesion, give more bits. Also, the deeper sections, serial sections, very important in this case. So with that limited what we got, I gave it in this category of NIF-TP. Now, could we have done the IHC in this case? Yes, we can do. How important, how useful? Let us see. If it was CK19, it would have come positive in a PTC, or HbME1 seen in PTC, and but is also sorry, it would have come positive if it was a PTC. TTF1 and thyroglobulin, it will only tell you that it is a lung origin, but it will not give more than this information. And BRAF V600 is important. It will be positive even in the mutated PTC cases. So the thing to tell this, if to prove whether it is a PTC or not, CK19, HbME1, galectin 3, these are the important 3 markers. Okay. So the take-home message in this case is NIFTP, when you make the diagnosis, when you talk to clinicians, when you tell them that this is not cancer, tell them that this is a reclassification, this is to reduce overtreatment. It has excellent prognosis. It has a very low risk of recurrence, and you have to avoid overtreatment. And if you correctly recognize NIFTP, it will prevent unnecessary total thyroidectomy or lifelong thyroid hormone suppression. So that's why whenever you make, even if you have given it as a well differentiated tumor of uncertain malignant potential, make it a point to pick up the phone, call the clinician, explain what it is, tell them that this is all the reclassification which is being done, so that he understands your diagnosis. He will not go for over treatment of the case, and inform them about the excellent prognosis of these kind of tumors. Okay, so that's why I selected. The limitation of this case is extensive sampling, extensive grossing not available, although we have just taken only serial sections. That's why the capsular invasion is still subjective. See, each one will have their own subjective approach to this particular case. That's why I thought that this case will be suitable for discussion. So thank you. Let me check in the chat box if there is any questions in this case.
Last.
Okay, is it required that all features to be present to give score of 0 or 1 for each category? Yeah, that's a good question. I told you that there are three criteria. We give 1, 0 or 1. Suppose you see nuclear enlargement, is it 0 or is it 1? Number 2, look at the membrane, give it 0 or 1. Third, look at the chromatin, give 0 or 1. So like that, you have to give the scoring. Even you can give 1 out of 3, 2 out of 3, 3 out of 3. Okay. To make a NIFTP, even 2 is enough, not necessarily all the three categories, all the three also not required. Okay. Yeah, I think that's all about the questions. Over to the next speaker.
Thank you, ma'am. I would like to invite Dr. Samir Ahmed P. from JJ Medical College, Davangere, to present case number 5.
Hello, ma'am. Am I audible, ma'am?
Yeah. Yes, sir.
Okay. My slide is visible, ma'am.
Yes.
Good afternoon, everyone. Myself, Dr. Samir Ahmed P., third year postgraduate from JJ Medical College, Davangere. I will be presenting the case number 5. The case history is as follows. 34-year female with uterine intramural fibroid. 2 histopathological slides were provided for the evaluation, slide 5A and 5B. This is the scanner view showing multiple tissue bits of the both slides. Section study from multiple tissue bits shows as neoplastic lesion composed of tumor cells arranged in nest, sheets, cords. This is an arrangement of the tumor cells. With these tumor cells showing epithelioid morphology, that is round to oval cells with eosinophilic to clear cytoplasm having fine chromatin and occasional nucleoli. This is a higher magnification view of the tumor cells showing the clear cytoplasm. At one of the foci, we can see perivascular distribution of the tumor cells. That is, tumor cells are arranged around the blood vessels, and these tumor cells also show the similar epithelioid morphology. Coming to the stroma, the intervening stroma shows extensive hyalinization with thick and thin-walled blood vessels and collagen bundles. This is stromal hyalinization with thick-walled blood vessels. And there was no evidence of cytological atypia, there was no evidence of tumor cell necrosis, and the mitotic count was low, less than 2 per 10 hyperfold. Coming to the summary, there is a neoplastic lesion composed of tumor cells arranged in nest, sheets, cords, and occasional perivascular pattern, showing the epithelioid morphology, that is round to oval cells having clear to eosinophilic cytoplasm with extensive stromal hyalinization composed of thick and thin-walled blood vessels, and there was no evidence of tumor cell necrosis, and the mitotic activity was less than 2 per 10 hyperfold. So based on the above morphological features, the differential diagnoses include the uterine tumor with epithelioid morphology. One is epithelioid leiomyoma, Next is perivascular epithelioid cell tumor, that is PCOMA, and endometrial stromal tumor with epithelioid morphology. This endometrial stromal tumor with epithelioid morphology is usually seen in high-grade endometrial stromal sarcoma, which will have high degree of cytological atypia, high mitotic index, and characteristic arteriovalvular vasculature, which is not seen in this case. So this is ruled out. And the close differentials are epithelioid leiomyoma and PCOMA. In epithelial leiomyoma, the tumor cells will show epithelioid morphology, that is round to polygonal cells with eosinophilic to clear cytoplasm. In PCOMA, the cytoplasm, similar epithelioid cells with eosinophilic granular cytoplasm can be seen. And the arrangement here in epithelial leiomyoma will be nest, sheets, cords, and it is well circumscribed. In PCOMA, the vasculature will be thin, delicate vessels surrounding the tumor cells. In some cases, there will be a perivascular arrangement. And in malignant cases, there will be infiltrative arrangement also. And coming to epithelial leiomyoma, there will be absent or mild atypia, less than 2 per 10 hyperfilled mitosis, and there is an absence of tumor cell necrosis. In PCOMA, we can see mild to moderate nuclear atypia with variable mitotic figures, that is usually less than 1 to 2 per 10 hyperfilled, with focal necrosis can be seen in malignant necrosis, PCOMAs. And the stromal hyalinization can be seen in epithelial leiomyoma, whereas in PCOMA, we can see stromal hyalinization, especially in sclerosing PCOMAs, sclerosing variant of PCOMA. Further, IHC needed to differentiate between these two tumors, that is, one with smooth muscle markers like SMA, Carl-Desmond, Desmin, and melanocytic markers like HMB45 and melan A. The smooth muscle markers like SMA, Desmin, and Carl-Desmond are positive in epithelial leiomyoma, whereas the melanocytic markers are characteristic of PCOMA, that is HMB45 and melan A will be positive in PCOMA. And PCOMA can also show smooth muscle actin positivity. CD10 can be done to differentiate between these tumors and endometrial stromal tumor, wherein the endometrial stromal tumor shows sarcoma shows CD10 positivity. Thank you. Thank you, ma'am.
Yeah. Okay. Full screen. Right?
Yes, ma'am.
Okay. Okay, Samir, thank you for that presentation. I think you have covered almost 100% of whatever I wanted to say. The only thing which you have not covered is obviously the IHC, which we have done, and I have the findings. Otherwise, I think it is a complete presentation. Congrats and very well done. I enjoyed your presentation.
Thank you,
So
ma'am.
this was a 34-year-old female with intramural fibroid. It was sent as an intramural fibroid, and gross it was a very small lesion, hardly 2 centimeters, and it was all in fragments. Okay, so nothing great about the gross. It's a small tumor, and all of you have seen the beautiful. When I first saw the slide, I said, no, this doesn't look like a leiomyoma. Where are the spindle cells? Where are the fascicles? Where are the intersecting fascicles? No, there are hardly any spindle cells were seen. All were very plump, epithelioid, rounded, and a lot of hyalinization. And immediately the pecoma came into my mind because in uterus, either it is leiomyoma or pecoma. These are the two entities which we will have to consider. Pecomas, not that we report very frequently. I might have reported just maybe 2 or 3 cases of pecomas. Otherwise, they are very rare. I haven't reported many. Leiomyomas are so common. Even the variants, epithelioid leiomyoma also, sometimes we can make out the plump nature. But here the hyalinization and then the vascularity, which Samir was showing and explaining very well, it was so characteristic. These were all around the vessels, and you can see them nigh dense hyalinization. Look at this empty clearing, and some of them had a eosinophilic cytoplasm, and some amount of ATP is also there, in the nuclei. They are little variable in their size and shape. And so this morphology, I thought, no, better I will do an IHC on this case and then only release the report. So we went ahead and we did the IHC. I was 100% sure it will turn out to be a picoma, and I would see a very nice. It's slow. The thing is not moving. Just a second, please hold on. My screen is not moving forward. Yeah. So this was the IHC findings. Okay. So Samir, I think this was the only thing lacking in your which you didn't have access to. All the melanocytic markers came negative. HMB45, S100, melan came negative, which was very weak positive, whereas all the smooth muscle markers, that is HCAL, Desmin, SMA, they all came positive. Ki67 was very low index, and this is the pictures of the IHC. You can see Vimentin, SMA being positive, PAN-CK was kind of weak, S100 negative, HMB45 negative, melan negative. TFE3 was weak and patchy. CD34 highlighted only the blood vessels and the endothelial cells, whereas the smooth muscle markers of HCAL desmone we came to the diagnosis of a epithelioid leiomyoma. So picoma was ruled out, as well as smooth IHC. Hence, we gave a diagnosis of a epithelioid leiomyoma. Now, this epithelioid leiomyoma, it will have this kind of rounded cells, granular or clear cytoplasm, and they are in nests, and or they may be in cords, trabeculae, etc. But sometimes they may have spindle cell component. In our case, there was no spindle cell component at all. So we saw only the epithelioid component. Picoma, I think, Samir, you have given all the points, and I will not go into that again, including sclerosing picoma, where stromal hyalinization is extensively seen. So, point you told was when we see such kind of plump epithelioid cells, stromal tumors also, you have a stromal variant of epithelioid variant of a stromal endometrial stromal sarcoma. However, that particular entity will not enter into the DD in this case. So I will not be touching upon that endometrial stromal tumor. Even Samir also, he just made a mention, but he did not go deep into that. I appreciate that point. So these picomas, they will have this typical TFE3 translocation. I think that's for the PGs to know. This TFE3, we did a TFE3, but it was kind of weak and patchy. And the IHC profile of picoma is the dual differentiation of smooth muscle and melanocytic marker. So that is a characteristic criteria for picoma, and it was a epithelioid leiomyoma. So the take-home message, when we see a uterine mesenchymal tumor with a epithelioid morphology, how do we approach them? Is it a epithelioid leiomyoma? Is it a picoma? Is it a stromal tumor? These are the differentials to be kept in mind. And definitely, IHC will play a role in deciding whether it is a picoma or a stromal tumor. Before I stop the discussion, let me just check the chat box if there is any questions on this case. Why was TFE3 done? So I think now you understand, because the gene rearrangement of fusion, which can be done either by IHC or by a molecular testing. Since we have the IHC, we try to do the TFE3 translocation for because the picomas are associated with the TFE3 translocation. Hence, we did the TFE3. I hope that answers your question. So thank you for your patient listening.
Thank you, ma'am. I would like to invite Dr. Rachna Nair from Koppal Institute of Medical Science to present case number 6.
Hello, Dr. Rachana. Please go ahead with your presentation. Dr. Rachana?
Yes, sir.
Yeah.
Hello, sir. My slide is visible.
Yeah, it is.
Hello.
Please put it to screen share mode. It's visible.
Uh, uh, Hello. Good afternoon, all. Myself, Rachna Nair, first year postgraduate from Koppal Institute of Medical Sciences. The case allotted to me is case number 6. The history given is 44-year-old male patient with excised mass, query anal papilloma, query malignancy.
Rachana,
This
can
is
you
the
please put
slide.
it to Rachana, Dr. Rachana, can you please put it to slide share mode and move the slides? Okay, it's moved to the first one, but it's still not in slide share mode. Click on the button on the lower right.
Sorry for the interruption, Dr. Rachna. Towards your right hand side, there is a slide PPT mode. Can you go for that?
Next to the percentage, zooming percentage, next to that, you can see an icon. Just adjacent to the zoom percentage. Yeah, just left of that area.
Down there were notes and zoom percentages there in between the first icon. Can you please go for that? Yeah.
Dr. Rachna, if you're not able to, please go ahead, but you'll have to move the slides individually.
Hello, sir. Is it visible now?
No, by the way,
Hello, sir.
when you shared your screen, did you select entire screen or did you select
Yes,
PPT?
sir. The PPT is
You must select entire screen, otherwise whatever is visible at that moment will only be visible to the rest of us.
okay, sir.
You stop share and start again, start share screen. Yeah, click on share screen and then you select,
Yes, sir.
yeah,
Entire screen.
correct.
Hello, sir. Is it now visible?
It's appearing all blank to me. Nothing is visible yet, Dr. Rachna. Yeah. Yep. Correct. Now it's visible. Click on the slideshow. Yeah. Great. Please start. Hello, Dr. Rachna. You're not audible. Are you saying anything?
Hello.
Yeah, you're audible. You're audible.
Sir, am I audible now?
You're audible, but there's an echo coming.
Oh, sir. Hello.
Yeah. Go ahead.
Uh, okay, sir. I have been allotted case number 6, with history of 44-year-old male with excise mass, query anal papilloma, query malignancy. Uh, this is the slide given to me. Uh, in this view, we can see epithelial lining showing focal areas of erosion or ulceration. In this view, we can see the subepithelium is full of congested blood vessels and fibrovascular stroma with chronic inflammatory cells. This is the same picture in 40x showing congested and dilated blood vessels with fibrocollagenous stroma. And this is the mucous sections from mucosa, which shows mucosal glands and chronic inflammatory cells. It's the same view in 48. This slide shows no evidence of dysplasia, and there is no breach of basement membrane. So, sharing the summary, the squamous epithelial line shows focal areas of erosion and ulceration. Subepithelium shows plenty of congested and dilated blood vessels, fibrocollagenous tissue, and many chronic inflammatory cells. Section study from mucosa shows plenty of mucosal glands and chronic inflammatory cells. There is no features of atria, no feature of basement membrane. For my differential diagnosis are hypertrophic papillae, inflammatory polyp, and condyloma acuminata. Hypertrophic papillae, also known as fibroepithelial polyp. Epithelium is hyperkeratotic and parakeratotic. Fibrovascular connective tissue core. Reactive stromal cells are present, and mast cells will also be present. Inflammatory polyp. Surface epithelium is composed of colorectal, transitional, and squamous mucosa. There is thickening of muscularis mucosae, extension of muscle strands into lamina propria, elastic fibers in the mucosa. There will be diamond-shaped grips. P53 and Pi57 is positive in areas of dysplasia. And third diagnosis is condyloma acuminata. In that, there will be costocytosis, inflamed fibrovascular stroma, and if this is due to low risk HPV, there will be features of no dysplasia. So based on the description of the slide, my probable diagnosis is hypertrophic papillae or fibroepithelial polyp. Thank you.
Thank you, Dr. Rachna. You've gone, you've pointed out all the findings in the slides very well. I'd like to just take you back to the slide. One second. Have you stopped sharing your screen?
Yes, sir.
Okay, I will start sharing my screen. Okay, is my screen visible?
Yes, sir.
Is it? It is okay. So nothing much in the history as far as this case is concerned. And on gross findings, it was partly skin covered and measured about 2 by 1.5 centimeters. External and cut surface were gray brown and nothing significant in that. So I will just go on to the slide straight away. So Dr. Rachna, is the slide visible now? Is the entire screen visible,
Yes,
the
sir.
entire slide? Yeah. Do you think the entire tissue here is a polyp, or do you think a part of it is only the polyp?
Sir,
What was your thought
part of
when you found this?
pa.
You thought only a part of it. I guess that is why you have differentials included hypertrophic papillae and condyloma accumulate, which will predominantly be polypoid lesions involving the squamous epithelium, right? Stratified squamous epithelium, right?
Yes, sir.
Okay, but you're also seeing a large portion of the colorectal type of epithelium. So you didn't feel that that was part of the polyp, or you thought it was a region above the polyp? What was your thought on this?
Sir, part of polyp.
You thought it was part of polyp. Okay, from your differentials of hypertrophic papillae and condyloma acuminatum, both should have a predominant stratified squamous epithelial lining. So if you think that this whole structure, entire structure that you're seeing here is a polyp, then it means that it has both stratified squamous epithelium and colorectal type of epithelial lining. Agreed?
Yes, sir.
Okay. So which among your differential diagnoses do you think you would favor now that um, we have we are in agreement that this is an entire polyp which has both these epithelial linings present? Would you like to give a different diagnosis, or do you like to be a little more specific in your diagnosis? The reason I'm asking you is because you said hypertrophic papillae, anal papillae, isn't it? Which is predominantly stratified
Yes,
squamous,
yes.
and condyloma acuminatum is also something to do with stratified squamous epithelium. And now we both agreed that this whole lesion is a polyp. Have you seen a lot of polyps in the GI mucosa? Have you seen something like this, which is so large and has not just a mucosal tissue but also underlying stromal tissue? Okay, okay.
Hello,
Let's.
sir. Sir.
Yeah, Dr. Rachna.
Yes, sir.
Okay, Rachna, we'll look at the slide in a little more detail, right? So here you have all the colonic crypts. Do they look very normal, or do they look a little unusual? Anything you would like to comment on this? You already mentioned the areas of ulceration. What about the morphology? Can you make out that there is a little bit of serration in some places, little irregular in its appearance? They're not uniform, like how you see in a normal colonic mucosa, where you find them as classically described as row of test tubes. So you do find some amount of irregularity. So the the colorectal crypts do show some irregularity. They look like hyperplastic, what you would see in a hyperplastic polyp. Do you agree? Okay.
Yes,
So a
sir.
part of it is lined by stratified squamous epithelium. Part of the polyp is lined by hyperplastic appearing colonic crypts. But what is most striking in this polyp, now that you consider that the whole lesion is a polyp, what is most striking is the stroma. Okay, there is a lot of stroma. So yes, a lot of stroma can be found in hypertrophic papillae also. But look at this one. What has happened here? This is an area of edema. You can see that it's appearing pale and the nuclei are spread apart. So this is an edematous area. And the rest of the stroma is a mixture of fibrous tissue. And if you look carefully, can you make out these bundles of smooth muscle? Dr. Rachna, is my
Yes, sir.
cursor visible? I made it a big green colored cursor. Is it visible?
Yes, sir.
So you can see these bundles of smooth muscle. And look at the orientation in which these smooth muscle fibers are. Normally, when you see the smooth muscle fibers beneath the crypt, either the muscularis mucosae or the deeper muscularis propria, they will run, parallel to the surface mucosa. But here you're seeing them vertically oriented, right? at right angles to this surface. So there are a lot of bundles of muscle tissue, smooth muscle tissue. If you look around, all these dark pink staining structures are muscle, and a lot of fibrous stroma. Plus, as you pointed out, blood vessels. Some of them are thick walled. Can you make out this thick walled blood vessel here? So they have thick
Yes, sir.
muscular walls. So the stroma is what is most striking as far as this case is concerned. Stroma is made up of a lot of fibromuscular elements and thick-walled congested blood vessels. And do you see here something? Do you see some elements of the mucosa here? Anything striking here? Do you want to comment on this? What do you think of this area? It's quite deep from here, right? What do you think of this area? Yeah, one aspect is that this could be a tangential orientation of the mucosal surface, or it could be what is known as epithelial displacement or misplacement, where some of the mucosal elements is driven into the deeper regions. So both are possible, right? But do not mistake it for a malignancy. So this is an entire polypoid tissue lined by both stratified squamous and colorectal type of mucosa. And let me come back to my PPT and let's see what our findings are. Okay. So to summarize, this is a polypoid lesion with predominantly colonic type of mucosa and also showing areas of anal mucosa. We saw that the crypts were not uniform. They had some irregularity and elongation. But what strikes me most is the abundance of hyperplastic appearing fibromuscular stroma. That is what strikes most in this case, along with the thick-walled congested blood vessels. And also there were inflammatory cells, which I did not really focus on, but it was quite obvious. If you really zoom in, you can see a lot of inflammatory cells throughout, not just in the mucosa, in the deeper regions also there are a lot of inflammatory cells. And we did not encounter any dysplastic change or evidence of malignancies. So considering a polyp with a mixture of colonic and stratified squamous anal mucosal lining with hyperplastic fibromuscular stroma, which is predominantly seen, along with thick-walled blood vessels and inflammatory cells, our diagnosis was inflammatory cloacogenic polyp. So, Dr. Rachna, you were right in one of your differentials where you called it inflammatory polyp, but I would have liked you to have been a little more specific and called it cloacogenic polyp because it's got both the stratified squamous and the colorectal type of mucosa. Okay, let's briefly discuss this entity, inflammatory cloacogenic polyp. This is relatively rare among the polyps of the lower GI tract, with less than 1% observed. They have a wide size range, ranging from 0.5 to 5 centimeters and a mean of 2 centimeters. Ours is roughly in that mean range. The important thing about the pathogenesis of inflammatory cloacogenic polyp is that this results in a mucosal prolapse due to increased pressure, intraluminal pressure in the anal region. So this is the reason why you are seeing all those elements in the polyp. The surface can be stratified squamous, columnar, or can also be transitional with appearance of both squamous and columnar. And because it's for obvious reasons, because it's protruding into the lumen and which is it is exposed to the fecal matter, it can undergo ulceration. The mucosa we've seen shows hyperplastic changes. Sometimes you can find displacement of mucosa where it is pushed into the deeper regions, and that should not be mistaken for an invasive malignancy. You can sometimes find pools of mucin without mucosal tissue elements in the deeper stroma. Chronic inflammation, areas of edema, granulation tissue formation, dilated vessels are all seen in inflammatory cloacogenic polyps. But the most important feature that helps us in diagnosing this entity is the presence of fibromuscular proliferation. And sometimes you can find reactive atypia, but this should not be mistaken for malignancy. So that's in brief about inflammatory cloacogenic polyp. So whenever you find a polyp in the region, in the anal region, which is made up of both the anal and colonic mucosa, and you find a predominant fibromuscular proliferation associated with chronic inflammatory changes, remember that this is nothing but a mucosal prolapse with secondary changes. And it's because the mucosa has prolapsed and it has pulled in the underlying connective tissue with its thick walled blood vessels that you're seeing all those changes in an inflammatory chlorogenic polyp. So for further reading, I would suggest you look up WHO Blue Book. It is despite being a non-neoplastic lesion, it is mentioned in the WHO Blue Book. You can also look it up in other textbooks of non-neoplastic GI pathology. So thank you, Rachana. Thank you for your nice presentation. Any queries? I think we can have them in the chat box. Yeah, Dr. Sujita says pseudo invasion. Yeah, that I thought that was maybe some kind of a tangential orientation, or maybe something which is caused by the biopsy itself. Dr. Chatura asks, is this part of SRU syndrome? Yes, all of them have kind of similar etiopathogenesis in that solitary rectal ulcer also has has an underlying cause in increased rectal or intraanal pressure, leading to formation of the SRUS. This also prolapse also has a similar underlying pathogenesis. So yes, they are all part of the same condition. Any other further questions, or we should move on to the case number 7? Thank you, Dr. Rachna. Thank you for your presentation.
Thank you, sir.
Thank you, sir. I would like to invite Dr. Arti Priya from Bida Institute of Medical Science to present case number 7. Good evening, everyone.
Go ahead, Dr. Arti Priya.
Entire screen. Good evening, everyone. My name is Arti Priya Khangambam, and I've been allotted case number 7 with the history of a 44-year-old male by biopsy from a growth in the buccal mucosa, and the query is whether it's carcinoma. In the scanner view, we can see an exophytic growth seen in the dermis, showing papillomatic outgrowth of the epithelium and prominent keratin layer. In 2x view, we can see tongues of squamous epithelium pushing into the dermis. The subepithelium shows mucus gland and congested blood vessels. I've marked the tongues of squamous epithelium with a red arrow, and the mucus gland with a yellow arrow, and the congested blood vessel with the green arrows. And in 4x view, we can see acanthosis, hyperkeratosis, and parakeratosis, and deep dermis showing muscle layers. In 10x view, we can see a band of lymphocytic infiltration with congested blood vessel below the basement membrane. I have marked the bands of lymphocytic infiltration with the red arrow and the congested blood vessel with the green arrow. In 40x, we can see intraepidermal spongiotic changes with a colloid body and a mitotic figure. I've marked the mitotic figure with the red arrow and the colloid body with a green arrow, and the intraepidermal spongiotic changes with the yellow. The area has been marked with yellow arrow. Coming to the summary, exophytic growth seen in the dermis, papillomatous outgrowth of epithelium with prominent keratin layer, tongues of squamous epithelium pushing into the dermis, and deep dermis showing muscle layers and minor mucus glands. And there's a band of lymphocytic infiltration and congested blood vessel below the basement membrane. We can also see acanthosis, hyperkeratosis, and parakeratosis. Coming to the differential diagnosis, it could be either early verrucous carcinoma or squamous papillomatosis or pseudoepitheliomatous hyperplasia. In early verrucous carcinoma, which is typically seen in 6 to 7 decade of life, it's more commonly seen in male than female. Gross morphology is almost same for all the three. So grossly it's hard to differentiate. But in early verrucous carcinoma, we see white or tan exophytic or either papillary or fungating cauliflower-like growth. Microscopy, it is well differentiated with cytologically bland hyperplastic squamous epithelium, and there is papillary hyperkeratosis with deep keratin clefting and broad bulbous rete ridges with minimal cytologic atypia. Underlying connective tissue shows band of inflammatory cells infiltrate immediately subadjacent to the epithelial proliferation. The IHC markers used are Ki67, P53, E-catherine, and MMPS, and squamous papillomatis. It can occur in any age, and grossly it appears like cauliflower-like exophytic tan white lesion. Microscopy, papillary proliferation with fibrovascular core of stratified squamous epithelium with variable hyperkeratosis and parakeratosis, and coilocytes are rare. Cytologic abnormalities typical for epithelial dysplasia is seen, and ISC markers P16 to differentiate whether it's HPV associated squamous cell carcinoma from non-HPV. Pseudoepitheliomatous hyperplasia, which can occur in any age, and it depends on the gross morphology, depends on the underlying diagnosis, but generally there is thickening of epithelium and tan. It can be pigmented if overlying a nevus or melanoma. Microscopy, there is thick elongation of overlying epithelium with bulbous or jagged or sharp interconnecting ridges. Keratin pearls are seen, and concentric keratinocytes with central keratinization, and it lacks nuclear atypia, and few mitotic figures can be seen. Salivary glands may show spilled mucin or necrosis, and IHC markers use are PAS stain or GMS or P53. Since the slide given to me shows well-differentiated and cytologically bland hyperplastic squamous epithelium with hyperkeratosis and broad bulbous rete ridges with minimal cytologic atypia with inflammatory cells, bands of inflammatory cells underlying the connective tissue, I've come to the final diagnosis of early verrucous carcinoma. Thank you.
Thank you, Dr. Artipriya. Yeah, you picked up all the salient points in that slide. So a nice presentation. If you can stop sharing, I will share my screen. Okay, my screen visible? Dr. Artipriya, is my screen visible?
Yes, sir.
Yeah, okay. Right. So we received two tissues, small tissues, which had warty surface on them, and nothing much as far as gross is concerned. Let me go on straight to the slide. Okay, these were the two bits of tissue. As you can see from this low magnification, it's a kind of predominantly exophytic lesion, and the lower margin is more or less straightforward throughout. There may be some hint that there is a pushing margin, which is probably the reason why Dr. Artipriya favored early verrucous carcinoma, but it looks predominantly exophytic lesion. Agreed? Okay, let's zoom into this area, and you can see that on the surface there's a lot of keratin. Dr. Arti, do you think this is normal in the oral cavity? Is it abnormal or normal?
Abnormal, sir.
Abnormal. So, okay. What happens when there is a lot of hyperkeratostic areas or a lot of keratin synthesis in the mucosa? What's a normal mucosal epithelial lining in the oral cavity? And what happens when there is keratin like this? What is the epithelial lining? Yes.
Stratified squamous epithelium.
Perfect. Perfect. Right. So, what do you know what happens when there is a lot of keratin in these areas? It's not keratinized normally, right? It's non-keratinized. So when
Yes, sir.
it gets keratinized, what
Yes, sir.
happens? Any idea?
Actually, the surface becomes harder, so
Okay.
irregular and
Okay. Okay. So what happens here is that there is a lot of keratin on the surface, and this becomes moistened by the saliva, right? When this becomes moistened by the saliva, the keratin becomes whitish in color, and therefore you get white patches in the oral cavity. So whenever you find keratinization in regions which are non-keratinized, like the oral cavity or the genital tract, and then the keratin becomes moistened uh, by the secretions, the salivary secretions or the secretions, then the areas appear as white patches, right? So this would have appeared as a white patch with raised warty surfaces, right? So let's look at the rest of the slide. So on the surface, you have these papillary or warty structures. You can see these papillary structures formed by hyperplastic stratified squamous epithelium overlaid by a lot of true keratotic or orthokeratotic lining with small patchy areas of parakeratosis, but predominantly orthokeratotic. And then the epithelial lining is markedly hyperplastic. The basement membrane looks intact throughout, and there are maybe a little bit of nuclear changes, probably reactive changes here and there, but not really showing any evidence of dysplasia. You agree with me, Dr. Artipriya? It's not showing much of changes that one could call as dysplasia. And
Yes, sir.
right, so yes, so it is a lesion where the epithelial lining is hyperplastic, shows these kind of papillomatosis, and on the surface there's a lot of hyperkeratosis. Another finding that I'd like to point out to you, which you already mentioned actually, is this band of lymphocytes running all across. See this band of lymphocytes all across? If it were the skin, what would you have called this? Any idea?
No, sir.
Okay, we would have called it a lichenoid infiltrate or interface dermatitis if
Okay,
it
yes.
were skin.
Yes, sir. No.
Okay, so all throughout you have this band of lymphocytic infiltrate, which to me is a very characteristic finding. In addition to the fact that you have all these verrucous surface with a lot of keratin being produced on the apical portions of the epithelial lining. So let me just summarize my findings. Hyperplastic epithelium. So we are seeing a lesion from the oral mucosa where there is hyperplastic epithelium with hyperkeratosis and a lot of papillomatosis, leading to the formation of papillary structures on the surface. The squamous cells are basically bland but may show some areas of reactive changes. There's a band of lymphocytes all along the subepithelial region, and we did not see any obvious dysplasia or malignancy. And you did think of early verrucous carcinoma. Maybe some of these areas do show some regions that look like there is an endophytic component, but I'm not really convinced in areas like this that it's actually producing a significant amount of endophytic lesion, and I would not really go into calling it developing into a verrucous carcinoma. But one never knows about that. So our diagnosis at the end of looking at all these lesions is, all these findings is proliferative verrucous leukoplakia. Uh, to be honest, this was something which I learned relatively recently, and it was actually pointed out to me by Dr. Varsha, who will be speaking next. So prior to my knowledge about this entity, proliferative verrucous leukoplakia, I might have released several reports with squamous papilloma, or as you reported, Dr. Arti, maybe early verrucous carcinoma also. Pseudoepitheliomatous hyperplasia was one of your differentials, but I'm not sure I would have called this a pseudoepitheliomatous hyperplasia because it does not have a significant endophytic component. Let me just spend a couple of minutes on discussing PVL. It's a relatively rare lesion. It's usually in the older age group. Ours is relatively younger, and it's not associated with any of the usual etiological factors in oral when we think of oral cancers. So it's not associated with smoking, alcoholism, viral organisms, including HPV. None of them are found in this lesion. It can occur anywhere in the oral cavity, gingiva, alveolar mucosal tissue, mucosal areas, the palatal tissue, and sometimes also in the tongue. Clinically, they go through a series of changes. They start initially as a flat focal lesion, which can become more diffuse in its nature. And if you do find something flat and focal, obviously you cannot differentiate it from leukoplakia, simple leukoplakia. When it becomes warty, then you can label it as PVL. And PVL is important because it has a potential to become malignant. So grossly, it can be a flat or a verrucous lesion. Dysplastic changes can occur and can lead to malignancy. The diagnostic feature that you will see in this is not only the warty surface with the hyperkeratosis, but also the band of lymphocytes which is present beneath the mucosa. The importance of this lesion, of course, is that it is potentially malignant. So when you're dealing with an oral lesion which shows a lot of hyperkeratosis on the surface, which should produce a leukoplakic appearance on gross appearance, and you see verrucous changes in the mucosa along with the lymphoid infiltrate, then think of a proliferative varicose leukoplakia. And whenever you're diagnosing a proliferative varicose leukoplakia, look for evidence of dysplasia and malignancy. So we reported this as proliferative varicose leukoplakia and added a note to the clinician saying that this is potentially malignant, and suggested that the clinician follow up, in view of its malignant potential. So you can read up further on this in either the WHO Blue Book, or there is an article by Thompson et al., which was released in 2021. This article further subdivided this PVL into 3 categories, but I'm not very convinced that we must adopt the 3-category substaging of proliferative varicose leukoplakia. I think that just the diagnosis of PVL is sufficient for us. So thank you, and any questions, please feel free to add in the chat box. Dr. Artipriya, thank you for your nice presentation. And you are a little off target, but I think you got all the points right.
Thank you, sir.
Let me just look up the chat box. Okay, there are answers to my questions: wet, keratin, and white. There is someone, Dr. Neetu saying verruca vulgaris. Dr. Chatra says intraoral lesion, so no epidermis or dermis, please. Yep, sorry, did I mention epidermis or dermis? I must apologize. It's submucosal connective tissue or mucosa. Is this a precancerous lesion? Dr. Marathi asks. Yes, it is a precancerous lesion. It is known to produce both dysplastic change and invasive carcinoma. So if nothing else, we will move on to the next case. And sorry if I described it as epidermis and dermis. Okay, we'll move on to the next. I will stop sharing. Case number 8, Dr. Nandini, I believe. Please go ahead and start sharing your PPT.
Okay. Sir, I'm able to, sir, whether my...
No, your screen is not visible. You haven't started sharing your screen yet, I think.
Sir, started, sir.
It's not visible to me. Is it visible to the others? Yeah, Dr. Nandini, then you stop sharing and restart share screen.
Okay, sir. Sir, now it is visible, sir?
No.
Oh. No, sir, it's
What message are you getting, Dr. Nandini?
uh, yes, we are getting the choose to what share the school pathology KCP organization. Uh,
You click on share screen.
yes, sir. I clicked, sir, but
Okay. Now you should get on the right. You should get entire screen. Chrome tab, window, entire screen. Right.
yes, sir.
Click on entire screen.
Yes, sir.
And now click on the what you see on the left your screen. Click on that. Have you clicked the black?
Yes.
Then you have to click share. Yep.
Go.
Right. Go ahead, Dr. Nandini.
Good afternoon, all. Myself is Dr. Nandini, DNB resident, Manipal Hospital, Old Airport Road, Bangalore. Cases which is allotted to our hospital is case number 8, and history is given is 19 years old girl, excision biopsy from pigmented lesion in the natal flap. This is the scanner view showing skin structure composed of epidermis and dermis. Epidermis, it is lined by keratinized squamous epithelium, and dermis shows tumor cells which is wedge-shaped configuration. On the lower view shows there is a tumor extending into the deeper dermis, and in this slide, the tumor shows there is extension into deeper dermis, and in this tumor shows extending into subcutaneous fat. In this, there is an a flattened rete ridges, and the granular zone area is seen with show the clear demarcation between the epidermis and the dermis. In the superficial dermis, it is shows cellular with melanocytes and also aggregation of the melanophages. These tumor cells are cellular, and it is more or elongated epithelial and spindle morphology. And these tumor cells are surrounded to adnexal structure and neurovascular structure. Uh, in the previous slides, there is an morphologically obscuring heavy melanin pigment. In this, there is an melanin on breach shows tumor cells which are like to melanocytes. As we see in the pigments are bleach. So as we can confirm the melanin pigment, these melanocytes are mild pleomorphism and prominent nucleoli. Come to summary, intradermal melanocytic neoplasm with no junctional or intraepithelial component, extending into deep domain subcutaneous fat with pushing margin with clear circumcision. Deep wedge-shaped configuration shows cellular. It is composed of epithelioid to spindle-shaped melanocyte with abundant melanin pigment, and also there is a good number of melanophages are seen. There is no evidence of maturation with depth. Lesions are encelic neurovascular and adnexal structure. There is no significant ATP or intense mitosis, and also there is no necrosis. With the history and the microscopic structure, I would like to say melanocytic. This is melanocytic neoplasm, which is predominantly dermal based, without epidermal tropism, without or few mitosis, and there is no necrosis. I would put on my diagnosis under dermal based melanocytic neoplasm. These are my differential diagnosis: deep penetrating nevis, pigmented epithelial and melanocytoma, and blue nevis. Thank you.
Okay. Thank you, Dr. Nandini. You've described almost all the findings that are present in the slide. I will add on a couple of points later on. Let me ask you, Dr. Nandini, honestly, when you first saw this under low power, what was your impression? Did you think your differentials are all benign, right? Not
Yes, sir.
malignant. Yeah. So when you first saw this on low power, what was your impression, honestly?
Sir, the tumor cells it arises from the superficial dermis. It is entered into the deep dermis, and it is also involving the subcutaneous, and
Yeah. Okay.
it is entering into the deep
Mm.
like subcutaneous fat and all.
Okay. So what did you think? So when you first put it under the microscope, what did you think? Did you think it was a benign lesion or a malignant lesion?
Uh, yes, sir. It is. I feel it is benign malignancy.
Okay.
Sorry, benign neoplasm, sir.
Now, despite the fact that you saw that there was evidence of invasion into the subcutis.
Yes, sir.
Okay. No, I would have thought that when I put it into the on my microscope and saw that there's a deep extension, my first thought was, is it malignant? Is it a melanoma? You didn't feel that? You thought it is benign despite the, maybe you zoomed
Yes, sir.
into the morphology straight away, did you?
No, sir.
You thought it is benign even despite the
Yes.
deep penetration, right? Okay, let's look at the lesion. As you rightly mentioned, Dr. Nandini, this is an entirely dermal lesion. There is no epidermal or junctional component, right?
Yes, sir.
And it is wedge-shaped, as you rightly pointed out. And did you feel it was symmetrical or asymmetrical? When you say
It is.
symmetrical, like if you draw a line along its margin, along the middle of the lesion, did you see that it was symmetrical on both sides, or did you feel it was asymmetrical?
I feel it is symmetrical.
Symmetrical. Okay, okay. Right. So it's more or less symmetrical. All right. It's more or less symmetrical, but it's wedge shaped, and unusually it's extending deep into the dermis, and it's also involving the uh, subcutis. Right. So I will just look at the other slide. We had two sections, right? This is the other section, and this looks a little asymmetric, right? Because of this part, but we don't really have the other part. This looks a little asymmetric, and this has a deep extension with a bulbous margin. Did you notice this bulbous margin? So
Yes,
the
sir.
edge was bulbous. It expanded when it reached the lower portion. See here how it's expanded. So the lower portion has bulbous expansion, but the middle portion is narrowed down. Okay. And as you have already described, you have all these lot of pigmented, deeply pigmented epithelial cells, which are a mixture of polygonal and spindle.
Excuse me, sir.
Yes, sir.
So
Yeah.
sorry for the interruption. The PPT is not visible, sir, on the screen.
Yes.
I'm showing this slide. It's not visible.
No, sir.
No, sir.
Oh, sorry. Oh, is it visible now?
Yes, sir. Yes, sir.
Oh, okay. Okay, let me start at the beginning.
Yes, sir.
So as you can see, as Dr. Nandini rightly pointed out, it's a completely dermal tumor, and it's got a wedge shape. And as she said, it is somewhat symmetrical along its axis. If you draw a line here, it's somewhat symmetric. But if you look at the second one, it looks a little asymmetrical. Look at this extension here. You're able to make out all that I'm showing, right?
Yes.
Everyone?
Yes, yes, sir.
Yeah, okay. So this slide looks a little asymmetric, but this slide has an important point in that the deep extension shows the bulbous end. The lower portion is expanded, forms a bulbous end. The first slide does not show much of a bulbous protrusion, but it does show the elongation into the subcutis. So when we zoom in, we see the two components, the polygonal and the spindle cells. So can you make out the polygonal and the spindle cell component? So both these are present. And when we go down towards the mid-dermis, somewhere in the mid-dermis, the diffuse sheet-like proliferation that we saw in the upper dermis. The upper dermis has this diffuse sheet-like proliferation. And in the mid-dermis, at some places, they become fascicular. Notice these fascicles, they're forming fascicles here. Notice this region, again, they're forming fascicles. So in the mid-dermis, they're forming deep fascicular kind of structures. And when it is reaching into the subcutis, it's forming a bulbous proliferation. I want you to concentrate on this area, this region. This region is where it is forming the fascicular appearing growth. Look at the structures here. Can you make out this structure? What do you think this is, Dr. Nandini? Look at this structure. This structure. What? There are different structures. 1, 2, 3, 4.
I think it is.
Yeah. Come on. I know you have the answer
Oh,
because you already described it in your PPT.
sir, though this one it is adnexal structure. It is.
Yes, yes. This is probably a eccrine duct, but here you can see a nerve fiber,
Yes, sir.
and this probably is a vessel, a capillary, and this probably is a neurovascular structure, and this is an adnexal structure. This probably is also an adnexal eccrine duct. So it's forming fascicles along these neurovascular bundles and the dermal adnexal structures. You had mentioned it, and probably you'd shown me an area where I think it was a cross section in your PPT. So this is a fascicular growth pattern along the neurovascular bundle or along the dermal adnexal structures. And this is the bulbous extension. And then this is the bleach section. I just want to show you that on morphology, you can see these polygonal cells in the bleach section, and you can see some of the more spindle cells in between. And you can look at the nucleoli. You do find nucleoli, but not the macronucleoli that you tend to associate with a melanoma. And if you scan around, you do not see a significant number of mitotic figures either. Okay. So these were the typical findings in the solution. Let me go back to my PPT. Okay, gross findings, nothing much. It showed a nodule of 1.5 into 1 into 0.7 centimeters, and grossly margins were uninvolved, as you could have made out. So in brief, predominantly it's a dermal tumor with symmetrical appearance, mostly symmetrical, typically wedge-shaped, with nests and diffuse sheets of both spindle and polygonal cells, and showing abundant cytoplasmic melanin pigment. And there are typically fascicles with bulbous ends, which are seen to extend into the subcutaneous fat tissue. Mitotic activity was very minimal. There was no necrosis, no involvement of the junctional or epidermal region, and the margins were free. So with all these findings, our diagnosis was deep penetrative nevus, DPN. So discussion on this, it can occur at any age. Mean is around 26 years. It can occur in head and neck, trunk, and extremities. And we saw all the typical features. I'll not describe that again. And the only thing that I need to mention here is that sometimes the DPN can show some atypical features like very large size, absence of symmetry, only diffuse sheet-like growth pattern without the fascicles or without the bulbous ends, high rate of mitotic activity, or more atypia than what you saw in this case. So when you find some atypical changes like this, you can call it an atypical deep penetrating nevus. Sometimes it may be difficult to differentiate it from a malignant lesion like a melanoma, in which case you're allowed to call it atypical DPN with uncertain malignant potential. So differential diagnosis, as far as I'm concerned, the lesion which has such a similar large lesion with a wedge-shaped morphology is a pigmented epithelioid melanocytoma, which does not have the fascicular pattern, which has only a diffuse pattern. It's often associated with overlying epidermal hyperplasia and shows a lot of melanophages, and nuclear atypia is supposed to be more than what you see in DPN. Of course, when you see the extension into the deep subcutaneous, you always would like to rule out a melanoma, which will be asymmetric, which will have more amount of invasive nature, and will show all the other usual features of malignancy. Third differential, which I would like to mention, is cellular blue nevus, only because cellular blue nevus is another condition which can extend into the subcutaneous fat and can show a bulbous extension, which we saw in DPN. So these two findings are seen in cellular blue nevus, but they predominantly have a spindle cell morphology. They do not have this mixture of spindle and epithelioid cells, and melanophages are also, like in PEM, in large numbers in cellular blue nevus. So that is a differential diagnosis because of the fact that it's extending into the subcutaneous forming a bulbous end. So our diagnosis is deep penetrative nevus, which is typically a wedge-shaped symmetrical lesion with a mixture of spindle and epithelioid cells. And the classical finding is fascicles with bulbous ends invading deep into the dermis and adjacent subcutaneous tissue, not showing any significant ATP or mitotic activity. So for further reading, look up the WHO book on skin tumors. So thank you, Dr. Nandini. Thank you for that nice presentation. And I wish you had picked up a couple of more points in that, which would have made your presentation complete in all its respects. So thank you again, Dr. Nandini. Any questions in the chat box? Okay, it's all about screen not visible. Okay. Right, Dr. Gopal asks, melan bleach. Are you asking what bleach we have done? We use a potassium permanganate for bleaching the tissue, which which is quite good, which helps us in looking at mitotic activity, looking at the nuclear features. So when a lesion is something like this, when you need to really differentiate it from malignancy or from any other lesion like PEM, then we need to look up the bleach section, which is of great help. Dr. Shakti Das asks, can it be a congenital melanocytic nevus? Well, I'm not sure congenital melanocytic nevus would be having this kind of a typical wedge-shaped configuration and forming the vesicles and extending into the subcutaneous, which is bulbous ends. I'm not sure if that is what is typical of congenital melanocytic nevus. Congenital melanocytic nevus can show what you generally see in an intradermal or dermal or compound nevus, with the additional finding that you find the nevus cells in very close relationship with the dermal adnexal structures. That's what you find in a congenital nevus. Dr. Gopal Parikh asked, does IHC help in the diagnosis? Not really. There are no specific markers which will help you in diagnosing DPN from any other lesion or in differentiating it from melanoma. It ultimately rests on your good old H&E sections. If there are no other questions, I'll stop now and hand it over to Dr. Varsha, who will be taking over the next couple of cases. Thank you again, Dr. Nandini, for your presentation. Dr. Varsha, it's all yours. And if anyone has any other queries, you can please message me or call me on these numbers. I'll just share with you my, yeah. You can please email me at santoshpath@yahoo.com, or you can call me up or WhatsApp me at 944-985-6605 with any other queries or any other aspects of these cases 6, 7, and 8. So thank you all for your patient listening, and thank you for taking part in this KCIAPM slide seminar. And Dr. Varsha, you're on next.
Yeah, Dr. Chaitra can present the case next.
Yes, ma'am.
Yeah.
Am I visible, ma'am?
Hello, Dr. Chaitra?
Yes, yes.
Yeah, you
Yes.
put it on the slideshow. Okay.
Good afternoon, everyone. Hello, ma'am. Am I audible, ma'am?
You're audible. Your presentation, I can't see it. Yeah, now I can see.
Good afternoon, everyone. Myself, Chaitra K, second year postgraduate student from Kidwai Memorial Institute of Oncology. I'll be discussing about case number 9. The clinical history which was given is 47-year-old male with history of lymphadenopathy and splenomegaly, provided one slide, bone marrow trephine biopsy. The whole slide view shows 14 intratrabecular marrow space and satisfactory for evaluation, and it is hypercellular for age. The lower magnification shows hypercellular marrow with diffuse infiltration of neoplastic cells. Admixed, there are scattered normal hematopoietic elements comprising of aggregates of megakaryocytes. In this field, we can also see erythroid islands and occasional myeloid cells. Here at the paratrabecular area, it shows myeloid progenitor aggregates. And at the lower part, the neoplastic cells are arranged in diffuse sheets, and background shows extravasated RBCs, or also called blood lakes. On higher magnifications, these neoplastic cells often exhibit a characteristic Friedek appearance, which is attributed to the pale cytoplasm and widely spacing the oval and indented nuclei and having a prominent cell-to-cell borders. At other areas, there are lymphoid aggregates with occasional interspersed plasma cells, which are also seen amongst the diffuse infiltrate of neoplastic cells. So to summarize, it is a bone marrow biopsy showing 14 intratrabecular space, satisfactory for evaluation and hypercellular for age. Erythropoiesis is reduced with occasional erythroid islands. Granulopoiesis is reduced and megakaryocytes are adequate, with the neoplastic cells arranged in diffuse sheets exhibiting a characteristic Friedek appearance, which is due to the abundant pale cytoplasm and widely spacing the oval and indented nuclei and having a prominent cell-to-cell borders. We can also see interspersed plasma cells with no hemoparasite or granuloma noted. With limited clinical details and morphological findings, my provisional diagnosis is bone marrow infiltration by hairy cell leukemia or low-grade lymphoma. Additional information required is clinical findings, lymphadenopathy, is it generalized or regional, peripheral blood counts and smear findings, and flow cytometry and IHC findings. So for essential criteria for hairy cell leukemia, on bone marrow biopsy, it should have a characteristic Friedek appearance with oval to indented nuclei, abundant cytoplasm, and prominent cell-to-cell borders, with strong positivity for CD20 and annexin-1 by IHC, or co-expression of CD20, CD11C, CD103, CD20 by flow cytometry, and the desired criteria is clonal BRAF V600E mutation. So my differential diagnosis is lymphoplasmacytic lymphoma and splenic marginal zone lymphoma. The features favoring for the hairy cell leukemia is the male predominance, history of splenomegaly, Friedek appearance in morphology, and the blood lakes. The features against are hypercellularity and lymphadenopathy, which is usually not seen in the early but in the later stages when the tumor burden is high. Coming to lymphoplasmacytic lymphoma, because of the history of male predominance and lymphadenopathy and splenomegaly with hypercellular marrow and aggregates of lymphoid cells with few questionable intracytoplasmic inclusions that were noted. And the features against are the age, where it is seen after 65 years, and the intermediate to large neoplastic cells, which were seen in our case, whereas in lymphoplasmacytic, it is small to intermediate cell. An increase in plasma cells will be noted. Coming to splenic marginal zone lymphoma, this is because of history of lymphadenopathy and splenomegaly and blood lakes. And features against are intermediate to large neoplastic cells, whereas in splenic marginal zone, it is small to intermediate atypical lymphoid cells, mainly in the intrasinusoidal region are seen. Thank you.
Thank you, Dr. Chaitra. That was a very short and crisp but very informative presentation. Yeah, is my screen visible?
Yes, ma'am.
Yes, ma'am.
Okay, so as already what we provided was a 47-year male with splenomegaly and lymphadenopathy. This came to us as a second opinion case, and the lab findings were of pancytopenia. And bone marrow aspirate was more or less hemodiluted, almost like a dry tap, with occasional atypical lymphoid cells. Bone marrow biopsy was done, and they had reported it as a suggestive of lymphoproliferative disorder. They had sent it us for IHC. So what we received both the aspiration as well as the biopsy slide. So on aspiration, what did we see? There were scattered atypical cells, and the other hematopoietic cells appear reduced. This was what was the morphology of these atypical cells? You can see here these cells are small to intermediate sized cells with and in some of them have indented nuclei, as you can see here. And here you can appreciate the ground glass chromatin, and there's no nucleoli apparent in any of these cells. There's no prominent nucleoli. The cytoplasm had these fine villus projections. You can see in many of these cells. And on bone marrow trephine biopsy, I'm not going to go into too much detail because she has explained beautifully, including the non-neoplastic component. So the neoplastic component was predominantly these Friedek appearance of cells due to the prominent cell to cell borders. Here also you can see few of those indented cells occasionally. And as she also pointed out, extravasated RBCs are seen, giving the appearance of blood lakes. We also did a reticulin stain, and on reticulin we saw increased fibrosis. So here you can see the lot of intersections and thicker fibers. You can call this a grade 2 fibrosis. And this is the reason why you get a dry tap. Because of this increased fibrosis, you get a dry tap usually. On IHC, what we found was CD20 and PAX5 was positive. Both are B cell markers. So now we know we are dealing with a B cell lymphoma. BCL2 was also positive. Cyclin D1 showed variable faint to moderate to occasionally strong positive, but it was diffuse. And Ki67 was not too high. It was around 15 to 20%. Now, what are the markers which are negative? CD5 was negative, CD23 was negative. So we have ruled out a mantle cell lymphoma, CLL bar SLL. Also CD10 is negative, so we have ruled out a follicular lymphoma. What are the key findings in this case? Clinically, this patient had splenomegaly with lymphadenopathy. The nature of lymphadenopathy, we don't have the details of that. The lab findings showed pancytopenia, and on bone marrow aspiration, you could see those classical hairy cells. Bone marrow biopsy was hypercellular with an interstitial diffuse infiltrate composed of cells having the fried egg appearance. IHC wise, all the B cell markers were positive, cyclin D1 was positive, and BCL2 was positive. So, with the available information, we gave a diagnosis of hairy cell leukemia. Ideally, I would have loved to have annexin A with us, but I think cyclin D1 is a good enough marker to give this diagnosis. If you see only the clinical picture, what are the diagnoses can you think of? You can think of myelodysplastic neoplasms, megaloblastic anemia, aplastic anemia, especially when you have splenomegaly with a dry tap and pancytopenia. You may get confused when there is patchy infiltration of marrow by HCL, hairy cell leukemia. They can also show some dyserythropoiesis. So when you in an aspirate, you may actually not get these hairy cells at all. So in those cases, biopsy is a gold standard, and biopsy is the most helpful modality of diagnosis for hairy cell leukemia. So the other differential diagnoses are include the splenic B cell lymphomas. In the up until the 2017 classification, splenic marginal zone lymphoma, hairy cell leukemia, splenic diffuse red pulp small B cell lymphoma, and hairy cell leukemia variant. These were all categorized under the general category of a mature B cell lymphoma. In 22, they have called this now specially as a splenic B cell lymphomas, and hairy cell leukemia variant is now renamed as a splenic lymphoma bar leukemia with prominent nucleoli. I won't go into too much of details here. I'll just tell you the key difference between these four entities. In peripheral blood, this red pulp lymphoma, they usually have these polar villi as compared to the circumferential villi. And the cells are also more monomorphic and have more clumped chromatin and not that ground glass chromatin as you see in hairy cell. Splenic marginal zone, as she mentioned, they are smaller cells and they usually are mixed with lymphoplasmacytic cells. In the splenic B cell lymphoma with prominent nucleoli, as the name suggests, they have a prominent nucleolus along with the villus projections around in the cytoplasm. Another distinguishing feature here is there will be increased high lymphocytosis and there is no monocytopenia in the one with prominent nucleoli. But in hairy cell leukemia, there is cytopenia, leukopenia, as well as monocytopenia. You will hardly see these atypical cells circulating in the peripheral blood. So in these cases, IHC is quite helpful. Annexin A is a very specific and sensitive marker for hairy cell leukemia. Unfortunately, we don't have this marker with us, but I think cyclin D1 is another such marker which helps in our diagnosis. On flow cytometry, CD11C, CD103, CD123, as well as CD25. These are markers which are specific for hairy cell leukemia, and they're positive in almost 100 cases, 100% of cases. So what is hairy cell leukemia? It is a very rare indolent B cell neoplasm accounting for around 2% of all leukemias. It is most common in middle-aged males, and where you see a clinical triad of splenomegaly, pancytopenia, and a dry bone marrow tap. On morphology, the bone marrow biopsy clinches the diagnosis. It is fibrotic and hypercellular, and there is increased reticulin fibrosis, and you see the fried egg appearance of these cells. Peripheral blood or bone marrow aspirate may or may not show these hairy cells, but if you see them, it's an adjunct to the or diagnosis. Splenic involvement is usually diffuse in the red pulp. It doesn't involve the white pulp. There is atrophy of the white pulp. And grossly, you see these blood licks, and the corresponding histology is seen as pools of red blood cells with aggregates of these HCl cells. Lymph node, as already mentioned, is very rarely involved in the early stages and is involved mostly in advanced diseases. So this is the spleen. As you can see, it is just covered with pools of blood, and there are aggregates of HCl cells scattered. Immunophenotype wise, all the B cell markers are positive, along with it CD11C, 25, 103, 123. Annexin A and cyclin D1 is positive. And annexin A, as I told you, is a highly specific marker for HCl. Most of these cases harbor the BRAF V600E mutation, which can be confirmed by molecular testing. These cases have very excellent prognosis since they respond very well to the first line of treatment with purine analogs. In case they are resistant to this first line therapy, they are also very amenable to BRAF inhibitor therapy, either alone or with rituximab therapy. And in cases where you see CD22 bright on flow cytometry, anti-CD22 immunotoxin therapy is also very effective. So the take-home message here is, when you see a middle-aged male with a triad of splenomegaly, cytopenias, and dry bone marrow tap, always have HCl at the back of your mind. And diagnosis relies on the morphology, especially the bone marrow biopsy, immunophenotype, and the above clinical triad. Annexin A1 is a key marker distinguishing HCl from other B-cell neoplasms, and early and accurate diagnosis is critical, as HCl is highly treatable with purine analogs like cladribine. Yeah. Any questions? Yeah, splenomegaly is absent in aplastic anemia. That's true. But you will have a dry tap, usually dry tap in aplastic anemia, and this is only clinically. I don't. Otherwise, aplastic anemia is not a very close DD. But in view of dry tap, I would just suggest you to rule out aplastic anemia as well. Then if there is patchy involvement and you get a marrow with not much of the tumor, then you will have to do a rebiopsy and confirm. Any other questions? So I think the next person can start with the presentation.
Thank you, ma'am. I would like to invite Dr. Sana from Hubli to present case number 10.
Hello, am I audible?
Yes, ma'am. Please share the screen, ma'am.
Yeah, yes, ma'am. Is my screen visible?
Yes, yes. Yes, ma'am.
Okay. Good afternoon to all. Myself, Dr. Sahana, final year postgraduate from KMCRI Hubli. The case alerted to my college is case number 10. The history provided is 51-year-old male with incidentally detected mesenteric mass, query lymph node, clinically asymptomatic. Two slides were provided. Coming to the first slide, in the scanner view, here we can see the complete effacement of the lymph node architecture, and the parenchyma of the lymph node is completely filled with almost equally sized follicles, and here we can see these follicles are going into the adipose perinodal adipose tissue, and in high power we can see this cracking artifact forming the proper nodules are seen, and at places here we can see the mantle zone lymphocytes are going into these follicles. When we uh, going into the high power view, we can see there is no any polarity of the follicles is lost here. Coming to the high power view, here we can see some small to medium sized cells which are almost the size of the lymphocyte having cleaved nuclei which are centrocytes, and also seen are some larger cells with the vesicular nuclei with prominent nucleoli having abundant cytoplasm which are centroblast, which are seen here. Uh, as I previously explained, the some of the mantle zone T lymphocytes are going into the follicles. This has been magnified in the this picture. Same has been magnified. This is the second slide. Here also we can see the total effacement of the normal architecture of the lymph node, and these follicles are going into the perinodal adipose tissue, and same centrocytes and centroblasts are appreciated in the high power view. Coming to the summary of the microscopy, section studied shows complete effacement of the normal lymph node architecture. The lymph node parenchyma is replaced by closely packed back-to-back arranged multiple follicles of relatively uniform size which is distributed throughout the node. These follicles are composed predominantly of a mixture of small to medium sized cells with cleaved nuclei and scant cytoplasm that are centrocytes, along with our large cells that exhibit vesicular nuclei, prominent nucleoli, and moderate to abundant cytoplasm are centroblast. The number of centroblasts averages approximately 8 to 10 per high power field. Focal areas show invagination of the mantle zone lymphocytes into the follicles. Cracking artifacts are noted around the follicles, highlighting their border. Infiltration of the neoplastic follicles into the perinodal adipose tissue is also identified. Based on this, I would like to give a diagnosis of follicular lymphoma grade 2. And I also like to consider differential diagnosis, that is nodular lymphocytic predominant Hodgkin's lymphoma. The main differences is in case of follicular lymphoma, the uh, follicles are uniform sized. In case of NLPHL, it is larger. The follicles are larger in size and it is irregular nodules. The cell composition in follicular lympho is mainly centrocytes and centroblast. In case of non NLPHL, it is small lymphocyte, histiocytes, and mainly popcorn cells are seen. The immun Coming to the IHC marker, in case of follicular lymphoma, it is mainly CD20, CD10, BCL6, and BCL2 positive, but NLPHL shows CD10 negative and BCL2 negative. How to grade is in case of follicular lymphoma, we have to consider number of centroblasts which are seen in high power, counting 10 follicles. So grade 1 constitutes 0 to 5 centroblasts per high power field. Grade 2 is 6 to 15 centroblasts per high power field. Grade 3 includes more than 15 centroblasts, which has 3A and 3B. In 3A, it has more than 15 centroblasts, but centrocytes are still present. 3B is where the centroblasts form solid sheets with no residual centrocytes. Thank you.
Yeah, thank you, Dr. Sahana. Very well presented. Okay. So case number 10, as we had provided, this was an incidentally detected mesenteric mass on routine check with no other symptoms. The patient was asymptomatic. So a follow-up PET CT was done and they found metabolically active lymph nodal tissue, which was encasing the SMA, measuring about 6 into 3.6 centimeters, along with multiple discrete prominent lymph nodes with mild mesenteric fat standing. But the stomach, small bowel, and large bowel were unremarkable. Serum LDH was within normal limits. And they excised two of the mesenteric masses and sent to us for HPE. So cut surface was great and solid. And on low power, as she mentioned, there were follicles of varying sizes and shapes, including some which were, serpiginous in shape, very irregular shape. And follicles which are going into the fat. This is the reason why you saw the fat standing on PET CT. On low bar alone, there were also few atretic follicles with some prominent mantle zones, as you can see here. So a DD of Castleman's was at the back of our mind, but once we went into the high power, I think that DD went out of the window. So on hyper, as already described, it was a mixture of centrocytes and centroblasts, very haphazardly arranged with no polarization. Conspicuously, there is no tingible body macrophages seen. Mantle zone was intact in a few areas. In few of the follicles, mantle zone was kind of intact. In few of them, they're lost, attenuated to lost. As you can see here, it is almost the cells are almost creeping into the interfollicular area even here. So here also you can see these centrocytes and centroblasts going into the interfollicular area. CD20 highlighted all the follicles. In few of the follicles, it was the CD20 positivity was limited to the follicular area, whereas in other areas, it was going into the interfollicular zone. CD10 is a germinal center marker. It highlighted all the germinal centers. Now here you can see some of the follicles are more pale stained compared to the others. Like here it is not that, it is a little darker stain. As well as you can see the CD10 positive cells going into the interfollicular area. CD23 showed intact follicular dendritic network. As Dr. Sana had mentioned about the differential diagnosis of nodular lymphocyte predominant Hodgkin's, in NLPHL, this CD23 network will be disrupted. So here it is intact. BCL2, it is strongly positive in many of these cells within the germinal center as well as few cells in the interfollicular area. Here also you can see these few cells here are quite dark compared to the surrounding cells, which are slightly lesser intensity. BCL6 also was positive in the germinal center, similar pattern as CD10. And Ka67 was relatively lower, around 20 to up to 30%. In a reactive node, you should have expected a higher Ki, but here it is low. We went ahead and did a BCL2 IGH fusion, which was negative by FISH. So what are the key findings in this case? This is an incidentally found lymph node with follicles of varying sizes, mantle zone intact to attenuated at places to lost, and follicles express B cell markers, the germinal center markers like CD10, BCL6, and BCL2 is strongly positive in the neoplastic cells. CD10 and BCL2 were also positive in many of the interfollicular area cells, and BCL2 IgH fusion is negative by FISH. Going by, if you ignore the BCL2 IgH fusion, this is a follicular lymphoma. So we gave a diagnosis of follicular lymphoma, but in a background of in situ follicular neoplasia. So follicular lymphoma is the most common indolent non-Hodgkin lymphoma in adults, which typically involves lymph nodes, but extranodal sites like mesentery are not uncommon. Now, should we grade a follicular lymphoma or not to grade? In up until the recent WHO says that there's not much statistical significant difference in clinical outcomes between grade 1, 2, and 3A. So, I mean, if you want, you can grade it, but it is not really helpful, is what we know now. So, what is the pathogenesis of follicular lymphoma? The most common rearrangement seen is follicular lymphoma with BCL2 rearrangement, that is the translocation 1418, which involves IgH and BCL2 found in 85 to 90% of cases. This BCL2 overexpression, this causes a BCL2 overexpression, which leads to these germinal center cells evading apoptosis. BCL2 is an anti-apoptotic protein. So when it is overexpressed, these germinal center cells, they evade apoptosis. Normally, what happens in a reactive node? Uh, when BCL2 is not overexpressed, there is somatic hypermutation. So, what somatic hypermutation does is there are a lot of mutations happening in the immunoglobulin gene. So, the antigen presenting cell, that is a follicular dendritic cell, presents an antigen to these germinal center cells, and only the ones which have the affinity, where the immunoglobulin has the affinity to these antigens, they will survive. The rest of the cells are useless. They don't have affinity, so they don't survive, and they undergo apoptosis. But in case of follicular lymphoma, these cells evade apoptosis, and these germinal B cells, even the ones which do not have affinity, they will remain. So when there is no apoptosis, you don't even see tingible body macrophages. But is this enough to cause follicular lymphoma? No, because you need, this is just one of the mutations that are seen in these BCL2 rearranged follicular lymphomas. There are multiple mutations that can occur, which actually leads to further progression to follicular lymphoma. So in normally in up to more than 70% of normal individuals actually have cells carrying these translocation 1418 cells, but not everyone will develop follicular lymphoma. You need to have additional mutations to progress to follicular lymphoma. In a minority of cases, that is around in a minority of cases, there is even BCL6 rearrangement, which may be in along with BCL2 or maybe in the absence of BCL2. And there are very rare follicular lymphomas which lack both BCL2 and BCL6 rearrangements. So in our case, we had BCL2 IgH negativity by FISH. These occur in 10 to 15 percent of follicular lymphoma cases. But why this occurs? Because in this case, okay. Yeah, in our case, BCL2 protein expression was there by IHC, but it was BCL2 was negative by FISH. The translocation between BCL2 and IgH was negative. What is the reason for this? It could be because there are alternate mechanisms that cause the BCL2 protein expression. That could be either gene amplification, epigenetic changes, or other translocation partners, like instead of IgH, it could be IgL. So we have to correlate with morphology and other IHC markers to come to a diagnosis of follicular lymphoma. Now, my second part of the diagnosis was in a background of in situ follicular neoplasm. Now, why did I call it in a background? Because there were follicles which had intact mantle zone, and there were BCL2 positive cells which are just restricted to the germinal centers of morphologically preserved follicles. Uh, so this is taken from WHO. How do you differentiate between a reactive node and a in situ follicular neoplasm? Many a times on HND you cannot differentiate because polarity can be maintained in an in situ follicular neoplasia also. So you need a CD10 and BCL2 to differentiate between these two. You can see the darkly stained CD10 follicles. These are and there are no CD10 positivity in the interfollicular area. So this, when you go to the corresponding area here in BCL2 is also positive. Whereas in the reactive germinal centers, they're all negative. You can also see here there is some partial involvement. So this is a in situ follicular neoplasia. Just zooming into the same image, a reactive CD10 in a reactive node is more pale stained, whereas in an in situ follicular neoplasia, it's dark. BCL2 in a reactive is negative, whereas in follicular neoplasia, it is positive and darkly stained. What are the clinical implications of in situ follicular neoplasia? It basically suggests a clonal evolution, and it requires very close evaluation to distinguish from overt lymphoma. So you never know. Possibly, if they had sampled another node, maybe a smaller node, we would have just seen in situ follicular neoplasia and not an overt lymphoma. So we have to sample more to actually find out the overt lymphoma component. Usually, they may be detected concurrently with or subsequent to follicular lymphoma at another site, or can even be associated with any other type of lymphomas, including DLBCL. In cases with concurrent clonally related in situ follicular neoplasia and follicular lymphoma, apart from what is already the common genetic events, there are other secondary events in follicular lymphoma that are not present in ISFN. So why do we need to worry about ISFN? Is there is some risk of progression to overt follicular lymphoma in 5 to 10% of healthy individuals, and the time to subsequent follicular lymphoma diagnosis range from 2 to up to 10 years. So take home message from this: whenever you see preserved appearing follicles and very florid appearing follicles, look for subtle signs of ISFN. They may or may not be loss of polarity, and IHC is very helpful in distinguishing between reactive and ISFN. BCL2 IgH negative follicular lymphomas, you have to rely on morphology, IHC, and along with the clinical context for a diagnosis. And recognizing ISFN is important to understand the clonal evolution and risk stratification. And a comprehensive diagnosis requires an integrated approach, including morphology, IHC, and molecular testing. Any questions?
Any chat box, no questions.
Yeah, no questions.
No
I think. Okay, so with this, we will end our session.
Yeah.
Yeah. So.
No, you sit.
Sit, sir. Thank you.
Aditya, you're there?
Hello, sir.
Dr. Aditya is there?
Sir had to leave for some meeting.
Yeah.
So,
Okay, then shall we close this session now?
yes, sir. Yes, sir. Thank you, sir.
Okay, I'll just give thank you remarks. Thanks everybody. In fact, we have been working last 1 month to make sure that these presentation go very well for the postgraduate students. Hope they all benefited from this. And at any time, I think Dr. Santosh has already given his number. You please contact us also for any requirements. Not only this, if you want anything like special stain or any special ISA markers and all that for any of your PG projects or whatever, you please approach us anytime. We are available, and we also have all the markers that is available in the market, especially the ISA markers. I want you guys stay in touch with us, and thank you so much. Okay, sorry for the inconvenience that has happened in the early part of the presentation. Hope everything went on well. Thank you so much.
Thank you, sir.
We'll take a small photograph now
And the
with our guys.
audience
Audience,
put up
be
their
audience. Can you just open up? Just yeah, e-video. Can you open your videos? Sultana, Asifa Sultana, then can you guys? Okay, no problem. Thank you. I think they're, yeah, they
yeah, now
come, they
they
come.
came.
Yeah, come. Thank you. Hi, Samir. She's, I think, what's her name?
So I'm Danishwari.
Yeah, Rajeshwari. She has one more girl come, I think. Rachana Nair. Yeah.
Everyone presented very well.
Yeah, yeah.
Everyone presented very
It was a very lively, live experience we had actually with you guys. All the best. Take care. Right.
Thank you, sir.
We'll meet again next year. Thank
Yes, sir.
you.
Thank you, sir.
Thanks.